So good morning everybody. So today we will cover the GIT and respiratory tract, which includes the hepatobiliary also along with the GIT, and obviously a few questions from the CNS. In the afternoon session we will come across the female and male genital system, including the breast pathology. So I am starting with this question. This is a very basic question of the UG level. In a patient with alveolar injury due to inhalation of sulfur dioxide, regeneration of alveolar lining occurs by proliferation of. Basically it is a chemical injury, sulfur dioxide, that is producing some sort of ARDS. So the question is actually, the regeneration is actually, obviously you know the answer lies between C and D, that is type 1 and type 2 pneumocytes, because the endothelial cells and pleural cells have nothing to do with any regeneration process. So what do you think, C or D? So again there is confusion between C and D. Definitely it is, the answer is type 2 pneumocytes. Why it is type 2 pneumocytes? The type 1 pneumocytes, they do the normal lining. So the normal alveolar lining is always by the type 1 pneumocytes, and ultrastructurally they look like flattened flat-like structure. The type 2 pneumocytes, you know the major function is production of surfactant. And again you see that ultrastructural body where the surfactant production is occurring in the lamellar bodies. They are called lamellar bodies, which is seen in electron microscopy, and this is the place where you get the surfactant production. And the second major function is the regeneration of alveolar lining. So whenever there is an injury, regeneration is always done by the type 1 pneumocytes. The normal lining is always by the type 1 pneumocytes. Okay. I think the second question given is actually the commonest cause of ARDS. I think that is like that, and that is the answer given there. It is sepsis. Sepsis actually they represents 50% of the entire causes of ARDS. I think this question is actually not there in the PowerPoint. So anyway, we will come on to that, the ARDS in detail. So here, I think this question is not there in the printout, I think. Restrictive lung diseases are characterized by all except. A simple question. What do you think? Reduced expansion of lung parenchyma, reduced total lung capacity, always a reduced forced expiratory volume at 1 second, and pneumoconiosis is the best example. See, definitely it's a simple question, and you see that restrictive lung diseases are always characterized by a marked reduction in the lung parenchymal expansion, and there is a reduction in the total lung capacity, and the FEV is actually, usually it is normal, or sometimes this can be show a mild reduction, otherwise it is normal, and pneumoconiosis is the best example of restrictive lung diseases. So the obstructive versus restrictive, you see that this is a very common question in both in the chest diseases as well as the pathology. Again you see that some highlights regarding the obstructive versus the restrictive. So the restrictive lung disorders are characterized by a normal or reduced forced expiratory volume. Usually it is normal. Chest wall disorders are the commonest causes. For example, any neuromuscular disorders like poliomyelitis, severe obesity, pleural diseases and kyphoscoliosis, where there is a obstruction in the chest expansion, as well as the chronic interstitial and infiltrative disorders. These are all examples of restrictive lung disorders. So I think this is the PowerPoint was missing, and it is a sepsis is the answer that given there. So ARDS is actually the pathologists who prefer to call this as actually diffuse alveolar damage, what is known as DAD. So these are actually common synonyms, ARDS versus a diffuse alveolar damage. Then other synonyms are the shock lung and acute alveolar injury. Whatever may be the terminology, the pathogenesis is actually very unique. What is known as, it is a diffuse alveolar capillary damage. A diffuse alveolar capillary damage. So this can lead on to life-threatening respiratory insufficiency, and this can again lead on to a severe arterial hypoxemia, which are refractory to oxygen therapy. That is, as far as the treatment is concerned, this is a major problem. That is, they are refractory to oxygen therapy and can progress to multi-organ failure. So these are the causes of ARDS. The major cause is actually infection, sepsis being the commonest individual cause. Then diffuse pulmonary infections, any sort of infection, a viral infection, atypical mycobacterial, and that is mycoplasma, pneumocystis carinii pneumonia, and miliary tuberculosis, viral, bacterial, any sort. Then physical injuries like mechanical trauma, you see a road traffic accident can induce pulmonary conditions, again a traumatic trauma, burns and near drowning. And inhaled irritants like oxygen toxicity and smoking, and chemical injury, heroin and methadone poisoning, aspirin and barbiturate poisoning. So anything can cause, and these are actually, according to the priority, I think the sepsis is actually being the commonest cause. Then rare causes can be hematological with multiple transfusion, pancreatitis, uremia, and hypersensitivity reactions. Okay. So the pathology is actually in a single sentence. It is actually a diffuse damage to alveolar capillary wall that is actually leading to a marked endothelial injury. Whenever there is a marked endothelial injury, this can increase the capillary permeability. So a lot of fluid will be escaped and there will be interstitial and intra-alveolar edema. As a result, there will be febrile exudation. So the whole pathology starts with a marked endothelial injury which can increase the capillary permeability. So interstitial and intra-alveolar edema and febrile exudation. The same sort of events you get in hyaline membrane disease due to a surfactant production, reduction in the surfactant production occurring in infants. And you see that again, I recall a question, I think 2006 or 5. In hyaline membrane disease, the hyaline membrane is composed of predominantly fibrin and necrotic cells. You see the pseudomembrane, it's not a clear membrane. You see that this is the hyaline membrane, seen in a hyaline membrane disease. And this membrane is actually composed of predominantly fibrin and necrotic cells. That was a question I think twice repeated in 2004 or 5 that time. So again a very common question, following a proof of a pulmonary infarct except. And from the infarction thrombosis you can expect any sort of questions. This can be for general pathology as well as a part of special pathology. And what is the answer? Yes, they are always a red infarct. And you actually again remember the organs where you get a red infarct as well as a pale infarct. And what are the difference between pale and red infarct? So most of the pulmonary infarct occurring in the lower lobe, they are truly red or hemorrhagic infarct. And correspond to the infarcted area, the pleura show a fibrinous exudate. And they are typically wedge-shaped infarct with apex pointing to the hilum. So this is actually a pulmonary embolism. How an emboli is differentiated from a thrombus, that is actually by microscopical examination. And you see that this is the typical pulmonary infarct. They are wedge-shaped, apex is pointing to the hilum, they are seen in the lower lobe, and they are red or hemorrhagic in color. So a thrombus is usually attached or incorporated into the blood vessel wall, and there is a point of attachment for the thrombus, but an emboli is totally free of attachment to the vessel wall. This is actually actually typically an emboli, even though this part is not seen in the picture, and otherwise it is an emboli because there is no firm attachment or this particular structure is not incorporated into the vessel wall. It is actually a feature of a thrombus. Thrombus, there is a point of attachment always. Occlusion of pulmonary artery by blood clot are almost always embolic in origin. You see that more than 90% of the pulmonary embolism, you see that this is actually from a deep vein thrombosis. They are always embolism and predominantly from the deep vein thrombosis, and pulmonary infarct is classically hemorrhagic and appears as raised red-blue areas. So they are typical example of a red infarct. So what are the causes of pulmonary infarct or pulmonary embolism which can lead to infarction? It is cardiac disorder, any disseminated cancer. Then this was the common cause maybe a couple of years back. Nowadays there are actually a lot of newer trends in actually the orthopedic departments, the surgery is considered. You see that the immobilization is actually not a part of post-operative section nowadays. You get mobilization immediately after the surgery. So this sort of causes is actually nowadays decreasing. There is immobilization for long duration, especially after hip fracture or a fracture femur. Then hypercoagulable states, which is the commonest hypercoagulable state, primary, it is nothing but factor V mutation. This is the most common hereditary hypercoagulable state, that is factor V mutation, followed by hyperhomocysteine and antiphospholipid syndrome. And the secondary causes can be obesity, recent surgery, as well as disseminated cancer. So this is the commonest primary inherited hypercoagulable state is actually a factor V mutation followed by hyperhomocysteine. So these are all causes of actually a pulmonary emboli. So the infarct is classified into red infarct and a pale infarct, red or hemorrhagic infarct. So the common scenario you get in a red infarct, they are due to venous occlusion. The best example is an ovarian torsion. They tend to occur in loose tissue. The best example is lung, and tissues with dual circulation, that is small intestine and lung. So the three organs involved by red infarcts are actually ovary, lung and small intestine. So you always get lot of exception question. All of the following are characterized by red infarct except, okay, and the white or pale infarct you get predominantly due to arterial occlusion, solid organ with end arterial circulation, that is heart, spleen and kidney. These are the solid organ that is affected by. Again, it's said the liver is actually said to be an organ where you can get predominantly a white or pale infarct. So these are the four organs. Ideally it is the three organs that is actually the prototype of a white infarct. Again you can add one more that is actually liver. This may be a tough question for you. In a lung biopsy of a patient with congenital heart disease, the arteriolar finding indicative of severe pulmonary hypertension is. This was the previous deeper question in a different way. See, any pulmonary hypertension due to any cause, they can induce intimal thickening. This is actually an important feature of pulmonary hypertension. Any pulmonary hypertension due to any cause, it can induce intimal thickening. This can induce medial hypertrophy because the smooth muscle cell may undergo proliferation and they can undergo hypertrophy, and this can induce a medial hypertrophy. When A and B are there, what is the next result? It is marked luminal narrowing. This is a common feature of any pulmonary hypertension. But something special in congenital heart disease with severe pulmonary hypertension, especially due to a left to right shunt, is a plexogenic pulmonary arteriopathy. Nowadays there is actually the cardiothoracic pathology is there, where they all, you see in high-tech centers where all these valvular heart disease are actually getting operated, and the pulmonary hypertension, they will be graded by the pathologist, and this is actually based on a system, and answer is a plexogenic pulmonary arteriopathy. This is unique to a congenital heart disease with a left to right shunt. You see that what is a plexogenic pulmonary arteriopathy? This is the lung biopsy. You see the lung tissue is there. You see the alveoli. This is the interstitium, and this interstitial blood vessel, they show a marked thickening. And this is the lumina actually. So the lumina is converted into fenestrations. So this is not a single lumina, it's actually what is known as a fenestration, converted into multiple fenestrations by a severe intimal and medial hypertrophy. And this is the silver stain. You see the lumina is converted into fenestrations or slit-like luminas, and this is actually due to intimal and smooth muscle proliferation. This is called a plexogenic pulmonary arteriopathy. So what is the simplest definition of a pulmonary hypertension? Normally the pulmonary pressure is 1/8 of the systemic blood pressure. When it becomes 1/4 of the systemic blood pressure, it is called pulmonary hypertension. So the pulmonary hypertension, you know, it can be divided into primary as well as secondary. Primary is usually idiopathic of unknown cause. And what is the gene associated with pulmonary hypertension, primary pulmonary hypertension? It is actually a BMPR2, what is known as bone morphogenetic protein receptor type 2. BMPR2, bone morphogenetic protein receptor type 2. There is a mutation in this gene which can produce a primary pulmonary hypertension. And this mutation can induce proliferation of endothelial, smooth muscle and intimal cells. That is why you get the thickening of the blood vessel, the narrowing of the lumen, etc. So congenital heart disease with left to right shunt, you classically you get plexogenic pulmonary arteriopathy. That is a tuft of capillary formation producing a web or network that spans the lumens of the dilated thin-walled capillaries. So the lumen will be converted into multiple slit-like luminas or fenestrations, and that is called a plexogenic pulmonary arteriopathy. All are true of pulmonary sequestration except. So what is a pulmonary sequestration? Definition wise, a pulmonary sequestration is defined as a discrete mass of lung tissue without any normal connection to the airway. It is actually a part of sequestered lung tissue which is not connected to the normal airway system. That is called a pulmonary sequestration. Okay. And blood supply to the sequestered area from pulmonary artery or its branches. It is not a correct statement. The blood supply is always should be from aorta or its branches, never from a pulmonary artery. A bronchopulmonary sequestration means that the sequestered lung tissue should not be connected to the airway system, and they should get the blood supply from the not from the pulmonary artery. It should be from the aorta or its branches. There is two types of pulmonary sequestration. What is known as extralobar sequestration as well as intralobar sequestration. What is extralobar sequestration? The sequestered lung tissue is seen. The sequestered lung tissue is seen in the thorax or in the mediastinum, not in the lung. You see that even though the intralobar sequestration means that the lung tissue is actually, the sequestered part is actually remain within the lung tissue, but they are not actually connected to the airway system. Extralobar means that it is outside the lung, that is within the thoracic cavity or in the mediastinum. Okay. And intralobar sequestration usually associated with recurrent lung infection because they are actually within the lung substance but not connected by airway system. So discrete mass of lung tissue without normal connection to the airway system. Blood supply to the sequestered area is always from aorta. That is an important feature. That is the definition, right? These two actually constitute the definition. Extralobar sequestration is occurring in infants, external to the lung, but anywhere in the thoracic cavity. Intranasal sequestration usually occurring in older children, often associated with recurrent localized infection. Okay. Don't confuse bronchopulmonary dysplasia and bronchopulmonary sequestration. Both are different, right? One is called BPD, the other one is bronchopulmonary sequestration. In a young man, the type of emphysema which can cause spontaneous pneumothorax always paraseptal type of emphysema. You know, the commonest type of emphysema is centriastinal. That is 95% of the commonest emphysema is actually the centriastinal. 95% belongs to centriastinal. Panacenar is rare, around 2 to 3% is panacenar, and you know it is associated with alpha-1 antitrypsin deficiency. The regular type of emphysema is actually, it is an incidental finding used in autopsies. They are not clinically symptomatic. So what is an emphysema? Abnormal permanent enlargement of air spaces distal to terminal. See, I have seen a question where they actually, what is the definition of emphysema is given as actually 4 choices. So again this definition is important. Permanent enlargement of air spaces distal to the terminal bronchiole plus destruction of their walls but absence of fibrosis. So permanent enlargement. You see, hyperinflation is actually not a permanent thing. So hyperinflation is not equal to emphysema because it is not a permanent enlargement. So permanent enlargement of air spaces distal to the terminal bronchiole plus destruction of their walls but there is no fibrosis. This should be differentiated from hyperinflation, and these are all anatomical types of emphysema. It's actually for the classification it is very important. So the paraseptal or distal acinar, the proximal portions of the acinas is normal, but distal portion is dominantly involved. So paraseptal or distal acinar, the proximal portion is normal, the distal acinar system is involved. Central acinar, as the terminology indicates, the central or the proximal portions of the asana is involved and the distal portions are actually not affected. Central acinar, the central part of the asana is affected and the distal part is actually normal. So the central or the proximal portions of the asana is involved. It constitutes 95% of emphysema, and this is the major cause is actually nothing but cigarette smoking. This is an emphysematous lung. What is known as an airy lung, too much of air in the lung. And this is actually a case in our forensic department where a young person succumbed due to spontaneous pneumothorax, and this is the paraseptal type of emphysema. They occur in young people and presented with bullous, you see that emphysema is bullous and undergoes sudden rupture and spontaneous pneumothorax. And this is a common cause for paraseptal emphysema to communicate like that. So the answer is a paraseptal type of emphysema. This is an emphysematous lung. See, but here we are not seeing the wall portion, so we cannot say it's a hyperinflation or emphysema. Genes associated with head and neck squamous cell carcinomas are all except P16, KRAS, P53 and cyclin B1. Answer is? Okay, it is the KRAS that is the answer. What is a P16 gene? This is an important question because it's a very common gene associated with head and neck cancer. P16 gene is actually called the CDKI, that is inhibitor of cyclin dependent kinase. P16 is actually an important regulator of cell cycle. So there you get the cyclin dependent kinase, the CDK as well as the CDK inhibitor is there, and the CDK inhibitor is called a classical P16 gene. This is associated with transition from normal to hyperplasia, hyperkeratosis, and occurs before the development of histological atypia. So this is actually the again the beginning. You get the P16 activation, and you see that this can actually so the most important gene is actually the P16 gene, followed by the P53 gene, and the cyclin D1 gene. So the cyclin D1 overexpression where you get this type of lymphoma, mantle cell lymphoma, cyclin D1 overexpression. Okay. And what is the translocation you get in mantle cell lymphoma? 11-14 translocation. What is it a low grade lymphoma or a high grade lymphoma? It is low to intermediate grade. It's not very low grade like a SLL or a follicular lymphoma. It is actually low to intermediate grade you get. What is a typical, suppose you get, will you get mantle cell lymphomas in GOT? Yes. There is nodal lymphoma as well as extranodal locations for mantle cell, and rarely this can occur in GOT. What is the classical percentage for mantle cell lymphoma in GOT? What do you call that? It is lymphomatoid polyposis. The lymphoma presenting as a polyp-like lesion for the GAT is always a mantle cell lymphoma. What is known as a lymphomatoid polyposis. What is a lymphomatoid papulosis? Papule-like lesions in the skin. It is actually cutaneous T-cell lymphoma. Lymphomatoid papulosis is actually a cutaneous T, predominantly a cutaneous T-cell lymphoma. Don't confuse that. Lymphomatoid polyposis. It's actually a GAT, a polyp-like presentation of a lymphoma, exclusively for a mantle cell lymphoma with 11-14 translocation. And what is the CD marker? Yes, it is CD5 positive, CD20 positive, CD23 negative. Okay. So the answer is KRAS here. Bronchopulmonary dysplasia is due to, don't confuse with bronchopulmonary secretion and dysplasia. Bronchopulmonary secretion is actually usually a infantile problem, and extralobar and intralobar secretion is there. And viral pneumonia, arrested development of alveolar septation, intrauterine sepsis, and abnormal vasculature of lung. So what is a BPD? This is called BPD, right? It is nothing but a hazard of oxygen toxicity caused by oxygen-derived free radical. Basically, the bronchopulmonary dysplasia is a hazard of oxygen toxicity caused by oxygen-derived free radical. There is high concentration of oxygen administered for prolonged periods. The two lesions that is produced by bronchopulmonary dysplasias are the retroverbal fibroplasia of eye, that is known as retinopathy of prematurity, as well as bronchopulmonary dysplasias. So the oxygen toxicity can induce two lesions. One is actually the retroverbal fibroplasia of the eye, what is known as retinopathy of the prematurity. So obviously this is occurring in premature infants, as well as the second one is actually the bronchopulmonary dysplasia. So this is simply due to oxygen toxicity. What is a bronchopulmonary dysplasia? The BPD infrequent in infants of more than 1,200 grams blood weight or gestation exceeding 30 weeks. This occurring in actually in infants who weigh less than 1.2 kg or the gestation is actually below 30 weeks. The recent definition, at least 28 days of oxygen therapy in an infant who is beyond 36 weeks post-menstrual age is required to render a diagnosis of a bronchopulmonary dysplasia. So, this according to rodents, actually I am not the pediatric, the neonatology, the rodents, the latest rodents say that at least 28 days of oxygen therapy. So what is a striking thing? You get a striking decrease in alveolar septation. So the major picture you get in the bronchopulmonary dysplasia is arrested development of alveolar septation. That is the key word. The BPD is always equal to arrested development of alveolar septation. Okay. Just to read that, because you see that the trend is actually nowadays you see you get a saturation level because the common questions asked because of this PG programs, again a lot of guides are available. You may be actually very thorough with the common questions. So nowadays they are going to the, see any basic concept in any MCQ level is actually 50% question is actually basic question. That is known by the average MBBS student. So an average MBBS student must know all these questions. Then 20-25% is actually what is known as nice to know area. So an average MBBS student is actually not expected to know all these things, but reasonably good student can actually aware of these questions. And the last 25% is very tough question. Only the cream of the student can actually come to that level. Okay, so any institute level of questions are there because 50% is over, only reasonable students will be there. And another 25% you see that only eliminating all the mediocres and you get the cream, the remaining 4. So this is a concept in any institute level of question and the scientific part of a question bank. Okay. This is a repeated question, simple question. Following the features of chronic bronchitis except. Many times repeated and you know this. It is a decreased read index. See, but this question is actually came once asked, what is the read index? What is the read index? They have given 4 choices and what is the read index? It is a ratio of thickness of the mucous gland layer divided by the thickness of the wall between epithelium and cartilage. The thickness of the mucous gland layer divided by the thickness of the wall between epithelium and cartilage. It is actually normal value is around 0.4 and according to the severity of chronic bronchitis, the read index value will be greatly elevated. So, you see the following features of chronic bronchitis, blood vessel hyperplasia. You get a definite thickness of the blood vessels, multi-layering of blood vessels. So, there is a marked blood vessel hyperplasia and the blood vessel usually contain large amount of mucin. That is why in chronic bronchitis, you always cough and produce a lot of mucin production. So chronic bronchitis is actually a chronic inflammation of the lung or bronchus. Any chronic inflammation of the bronchus is producing a squamous metaplasia. For example, chronic cervicitis, what do you get? The endocervix is actually covered by a squamous epithelium instead of the columnar epithelium. Extreme squamous metaplasia. So the normal bronchus is always lined by a pseudostratified columnar epithelium, ciliated, which are actually undergo a squamous metaplasia. That is why you get squamous cell carcinoma in the lung. Otherwise, it should be always adenocarcinoma, right? Because the columnar epithelium always gives rise to adenocarcinoma. Here, because of extreme squamous metaplasia, you get a squamous cell carcinoma. And in this read index, and anywhere you get chronic inflammation, that is the ultimate event, fibrosis. Tuberculosis, what is the ultimate thing? Fibrosis. Crohn's, it is again a structure of fibrosis. Okay. Kaplan syndrome is known to occur with the following except asbestosis, borreliosis, convergence pneumoconiosis, and silicosis. Again a simple question, answer is no, it is borreliosis, right? It is borreliosis. So the prototype is convergence pneumoconiosis, where you get a rheumatoid arthritis with a nodule, that is a pneumoconiosis. Rheumatoid arthritis with pneumoconiosis, and this lesion is actually seen as a distinctive nodular pulmonary lesion with the central necrotic areas. So the exception is borreliosis, and under that borreliosis is the classical granulomatous condition. It is characterized by granulomas. Following a proof for malignant mesothelioma except most of the mesotheliomas are actually malignant, but you see that the grade can actually differ, so it is called a malignant mesotheliomas. Strong staining for keratin and calretinin, ultrastructurally presence of low microvilli, can be a biphasic tumor, PAS positive diastase resistant tumor cells, difficult to differentiate from pulmonary adenocarcinomas. See, regarding the last choice, when you get a malignant mesothelioma, you know that it arises from the pleura. mesothelial cells, that is actually the pleura. So it is a pleural malignancy originating from the pleura, usually in the mediastinal aspect. So the duty is always whether it is actually a pulmonary adenocarcinoma, metastasis basis or mesothelioma. It is very, very important as well as very, very difficult sometimes. Because you know, lung is a common site for any adenocarcinoma metastasis. Most of the adenocarcinomas, they metastasize to lung. So it is common to get multiple lung mets or a single, sometimes it may be a single lung mets in the pleural aspect or in the lung substance. This should be differentiated from a mesothelioma. So this is actually an absolute right statement. Can be a biphasic tumor. Yes, mesotheliomas are biphasic tumor. May not be always. What is a true biphasic tumor? Primary sarcoma. To list out the biphasic tumor, primary sarcoma, mesotheliomas, carcinosarcomas. So again you come across questions. Carcinosarcomas are commoner in uterus. What is the older terminology? Malignant mixed Mullerian tumor. Triple MT. MMMT. Malignant mixed Mullerian tumor is nowadays known as carcinosarcoma. Here you get carcinomatous and sarcomatous areas. Mesothelioma, is it a carcinoma or a sarcoma? It's a carcinoma. Mesothelial carcinoma basically. Mesothelioma. Just like melanoma. Melanoma is a melanocarcinoma. But they call it a melanoma, right? Mesothelial carcinoma. But here they have epithelial-like pattern as well as spindle cell pattern is there. That is why it is called a biphasic tumor. Because usually you see that any tumor, as far as the histology is considered, the sarcomatous part is usually represented by spindle cell and the carcinomatous part is represented by epithelial cells. So you get a mixture of this. But again the sarcoma part, the spindle cell, they actually show the classical carcinoma markers. That is why we call this a carcinoma, right? Okay. The markers will be positive, but histologically they mimic spindle cells. So it is called a biphasic tumor. Okay. Can you mention any benign biphasic tumor? Pleomorphic adenoma. It is pleomorphic adenoma. All these are actually malignant. So it can be a biphasic tumor. Which is the true triphasic tumor? Means tumor. Means tumor is a triphasic tumor. It is again a question. A triphasic tumor is nephoblastoma or Wilms tumor. Right? You get epithelial elements, you get strong elements, you get blastomy elements. Triphasic. Three types of tissues are there. Strong staining for keratin. Definitely cytokeratin will be positive because cytokeratin is the brand marker for carcinomas. That is also a broad spectrum marker. Suppose you get, what is the histological hallmark for any carcinoma? That is under a microscope. Grouping. Grouping is a feature. The tumor cell may form groups. Grouping is a feature for carcinoma. For example, in a squamous cell carcinoma, you can see that the cells, they form lobules, clusters, and individual cell, they show keratinization. That is called a squamous cell carcinoma grouping. In an adenocarcinoma, the groups are in the form of glands. It is a grouping. In a melanoma, there is a nesting pattern. It's again they form groups. Right? But lymphoma, they never form groups. They are well separated cells. Each cell is separate from the other. Right. So in poorly differentiated carcinoma, the grouping is barely visible under the microscope because of the poor differentiation. Okay. In poorly differentiated carcinoma, it is sometimes very difficult to say it's a carcinoma. I can say it's a poorly differentiated malignancy. So this can be a carcinoma, this can be a lymphoma, even this can be a sarcoma. So what I can actually give by light microscopic examination is it is a poorly differentiated malignancy because of the extreme cytological atypia, mitosis, necrosis, everything is there. Then how actually I separate this, because it's very important to differentiate each one from the other. Because lymphoma needs only chemotherapy, right? We never need any surgery for lymphoma. But a carcinoma needs always surgery, chemotherapy and radiation. And sarcoma has its own protocol of treatment. Okay. So how will you actually differentiate? I pick some broad spectrum markers. I may do a cytokeratin. If the tumor cells are CK positive, this is branded as carcinoma. If CK is negative, it is not a carcinoma. Then I will do a leukocyte common antigen, LCA. That is known as CD45. Leukocyte common antigen is a broad spectrum marker for lymphoma. LCA is positive, which could be a lymphoma. Then LCA is negative, right? CK is negative, LCA is negative, I may do a binding to suggest that it is a sarcoma. Okay, these are the broad spectrum. So, cytokeratin, LCA, leukocyte common antigen and binding. Then suppose it's again LCA is positive, it's a lymphoma. Then again I will do a B cell marker and a T cell marker to again subclassify the lymphomas, right? Okay. So this is calretin is a very good immunomarker for mesothelial cells. Calretin is the marker. Cytokeratin will be positive in any, even adenocarcinoma metastasis, the cytokeratin will be positive because it's a carcinoma, right? So calretin is the best marker. And ultrastructurally, they will be characterized by low microvilli. This is the classical ultrastructure. PAS positive and diastase resistant tumor cell is nothing to do with the malignant mesothelial cell. And that is meant by that. PAS positive and diastase resistant tumor cells, it is not glycogen. The material is not glycogen that is seen within the cytoplasm. PAS positivity is always indicated in when you see that the cytoplasm is actually filled with some material, glycogen or non-glycogenic substances. Suppose it's a Gaucher disease, you know it's glycogen that is present. And I may do a PAS stain and the hepatocyte they show extreme PAS positivity. The inference is this can be glycogen or a non-glycogen substance like mucin or something like that. Because PAS can induce positivity for mucin also. So my interest is actually whether it is glycogen or not, right? So what is the next thing I do? I take another section from the block, another section, and I pre-treat with diastase enzyme. For example, we use earlier we use saliva. You see that actually the technician spit on the slide, right? Okay. The saliva they contain diastase, right? So if it is glycogen, the entire glycogen will be removed by diastase enzyme. Subsequently, you again stain with PAS. What is the result? PAS negative. So what do you call this? PAS positive and diastase sensitive is equal to glycogen. If it is mucin, that is a non-glycogen substance, after pre-treatment with diastase, the entire material will remain there because it's not glycogen. Again, they show a subsequent staining of PAS, they show positivity. So I will call that they are PAS positive and diastase resistant. It's very important, right? So that is the answer here. This is the mesothelioma. You see that it's the thickened pleura that is covering the mesothelioma tumor. Normally it's a spinal cell tumor. You see the spinal cell nature here. Bronchogenic carcinoma versus mesothelioma is actually a great problem. It arises from either visceral or the parietal pleura. So you can get the mesothelioma in the abdominal cavity as well as in the pleural cavity. And 90% of reported mesotheliomas are asbestos related. The causal etiology wise, the etiology related, I think the most important asbestosis associated with malignancy is actually mesothelioma, as according to the causal etiological relationship. But incidence wise, This is bronchial carcinoma. Because asbestosis can associate with bronchial carcinoma as well as mesotheliomas, as well as some other malignancy, we will come across that. But constant relationship wise, it is mesothelioma, because without asbestosis, we never get mesothelioma. But even without asbestosis, we get a large number of bronchial carcinoma, because the major cause can be cigarette smoking. Right? But incidence wise, we should say that the bronchial carcinoma is the first one, then only this mesothelioma. Because the incidence of mesothelioma is getting very uncommon. For us, we roughly get one case per year, because our biopsy number is actually around 22,000. I think the biggest, maybe secondary value, CMC value. CMC value have the highest number. Even Trivandrum, we actually just crossed the Trivandrum mark, it's around 20,000. And even then we actually come across maybe one or less than one case of mesothelioma per year. It is actually extremely uncommon. But whatever mesothelioma we get is due to asbestos exposure. So what is the classical history you get? A shipyard worker. So when you get a history like this, a shipyard worker, you think about mesothelioma. Now, increased risk for asbestos workers who smoke is very important. You see that an asbestos exposed worker who smoke never increase the risk for mesothelioma. There is no concomitant increase in asbestos workers who smoke for mesothelioma, but this is greatly elevated in bronchogenic carcinoma. Right? You understand? Okay. The risk is 5-fold for carcinoma, but 1,000-fold for mesothelioma in pure asbestos exposure, but incidence wise, it is bronchogenic carcinoma that is actually more. So these are the cytogenetics. Deletions in chromosome 1p6q3p. It is a biphasic tumor. Mesothelioma versus adenocarcinoma metastasis is a common problem. Strong staining for keratins, the accentuation of perinuclear pattern. Even the keratin staining is actually, the pattern is actually different. It's not important for you. Positive staining for acid mucopolysaccharide is not PAS. It is acid mucopolysaccharide which is inhibited by previous digestion by hyaluronidase. That is it's not PAS possibility that is important for mesothelioma. It is staining for acid mucopolysaccharide which is inhibited by previous digestion by hyaluronidase. And lack of staining for carcinoembryonic antigen, but this is positive in adenocarcinomas. Another useful thing is actually the CEA positivity is actually in adeno, not in mesothelioma. Positive staining for calretinin, W21 gene and cytokeratin 5-6. So this is the molecular weight, cytokeratin 5-6. This is the marker. Calretinin CK56 positive. Electron microscopy, presence of long microvilli and abundant monofilament is said to be the gold standard. But we don't actually use the EM study. We go for the calretinin with cytokeratin 5 and 6. Okay. All of the following tumors are associated with asbestos exposure. Except, the question is except, which is the exception? Answer is? No, it is carcinoma esophagus. You see, one thing the bronchial carcinoma is missing here. So, mesothelioma, bronchial carcinoma, mesothelioma, CA stomach, CA colon, CA larynx, and not the CA esophagus. Okay. I will actually show a chart where all this is given. All are pathogenic forms of asbestos except. Answer is actinolite. Is not correct. You see that how the asbestos fibers are divided into two groups, the serpentine and amphibo. What are serpentine fibers? They are curly and flexible. Right? When a fiber is curly and flexible, Are they less pathogenic or more pathogenic? They are less pathogenic because they may adjust to the bronchial lumina and doesn't cause much lung pathology. But the amphibole group, they are straight, stiff and brittle. If a fiber is straight and stiff, they can do some harm to the lung parenchyma. The best example of serpentine is chrysotile, and luckily this form is the most widely used. They are innocent and less pathogenic and the most commonly used. Amphibole, that is ammocyte, the crossovillite, the tremolite, anthophyllite and actinolite are more pathogenic. So what is the answer? It is chrysotile. That is why, see, every day we come across asbestos exposure, we get less number of diseases because chrysotile is the most commonly used fiber. Okay. So coming to the question, the less pathogenic is chrysotile. Crossovillite, ammocyte, actinolite, all are pathogenic because they belong to the amphibole group. Okay. Understand? So development of pneumoconiosis depends on the amount of dust retained in the lung, the size, shape, buoyancy of the particle, and the particle's solubility and the physical-chemical reactivity and additional effects of other irritants, for example smoking or something like that. Most dangerous particles range from 1 to 5 microns. This is the optimum size of a fiber to produce a pneumoconiosis, 1 to 5 micrometer in diameter, because they may reach the terminal small airways and air sacs with this particular size. So again this actually asks this question, the optimum size of fiber to produce pneumoconiosis is actually 1 to 5 micrometer. Okay. So may not be very evident from the back. This is from rodents. You see that some tables or charts are extremely important. It's not easy to read the whole thing. You see that, for example, you see this is asbestos. Asbestosis, they produce asbestosis. The Kaplan syndrome. You see that the coal dust, they produce Kaplan syndrome. The silica, again producing Kaplan syndrome. Asbestos, again producing Kaplan syndrome. And beryllium is not a cause for Kaplan syndrome. And coming to the asbestos, what are the malignancies associated? Apart from the mesothelioma, carcinoma of the lung is very important, the laryngeal, the stomach and colonic carcinoma. Right? This is asked as a question because, you see, when this question is even actually we think of this severe stomach and severe colon because not usually it is actually given in textbooks, but you see that there is association of the severe colon and severe stomach. Then what is siderosis? It is iron oxide. What is barytosis? It is barium sulfate. What is stylosis? It is tin oxide. What is hypersensitivity pneumonitis? It is Farley's lung, bagasosis and Bede-Bede's lung. So this is actually important. What is business? It is textile manufacturing. In lung, the microscopic findings suggestive of asbestos exposure is, it is in symbol. What is the answer? Ferruginous bodies, right? Very good. The astral and human bodies, sarcoidosis, right? Okay, Cashman spirals and charcoal-laden question, bronchial asthmas. So this is an asbestos body. You see that this is the highly magnified view of an alveolar space. This is alveolar. Where you see an asbestos body is there. It is a golden yellow, long golden yellow structure with beaded margins. You see it's a long cylindrical structure, golden yellow in color with beaded margins. So immediately when this is seen within the alveoli, what is the immediate body reaction? The carbon-laden macrophages will come and attack this. Immediately try to phagocytose them. So since this is a very long structure, they are unable to do so, right? Because you see that this is the macrophages, they cannot ingest the long cylindrical structure like this. So in the process of attempted phagocytosis, what happens? The proteinaceous matrix of this particular macrophages will be laid upon this cylindrical structure. You see that the cytoplasm is actually partially, it is actually stick to this. The proteaceous matrix will be laid upon this structure. And what is this proteaceous matrix they contain? They contain lot of iron. How? Macrophages eat lot of RBCs. Right? RBC contain hemoglobin. Hemoglobin contain iron. So the proteaceous matrix they contain lot of iron. This iron will be actually is supplemented to the this asbestos structure. So I can do a Prussian blue stain and found that this asbestos structures are Prussian blue porosity, and these are called ferruginous bodies. Okay, the significance is that the asbestos fiber never contain iron in pure form. The iron is donated by the macrophages in the process of attempted phagocytosis, and these are called ferruginous bodies. Right? This is a Prussian blue stain. Asteroid body and Schumann bodies, they are feature of sarcoidosis, but it is non-specific. They are seen in borreliosis and even tuberculosis. The present textbooks say even in tuberculosis you can get the asteroid body and the Schumann body. Asteroid bodies are stellate inclusion seen in giant cells, and Schumann bodies are laminated bodies of calcium and proteins. Asbestos bodies appear golden brown, fusiform or beaded rods with a translucent center and consist of asbestos fiber coated with an iron containing proteinaceous matrix. Following a tour of adenocarcinoma flank except the commonest type of movement, hilar bar central location, 75% associated with smoking, X-ray resembles a patch of pneumonia. What about C? The common grading given in textbook, especially in government, is actually adenocarcinomas are common in women and non-smokers. That doesn't mean that most of these people are non-smokers. Actually, they are associated with 75% associated with smoking. But even in non-smokers, you can get adenocarcinoma. What is the association of smoking with squamous cell and small cell? 98%. You never get a small cell carcinoma. You see that recently one of our is the confidential assistant lady. She got this small cell carcinoma. You see that again nowadays we get a lot of cases without any smoking association, especially in females. You see that. So, but adenocarcinoma, the association with smoking is slightly less when you compare this squamous and small cell. And even in non-smokers you can get adenocarcinomas. That is when females you get more adenocarcinomas. And they are always peripheral lesion, never be hilar or central location. So the abdominal carcinomas are divided into squamous cell carcinoma, small cell carcinoma, adenocarcinoma, large cell carcinoma, adenosquamous carcinoma, and carcinoid tumor. These are the subtype, histological subtype. Squamous cell, small cell, adeno, large cell, adenosquamous, and carcinoid tumor. Adenocarcinoma, according to the histology, asthena, papillary, bronchoalveolar carcinoma, solid and mixed. At least remember that there is actually asthena, papillary and bronchoalveolar carcinoma is there. The commonest are squamous, small cell and adeno. Large cell, adenosquamous, all are actually extremely rare. So this is actually the male percentage female. Adenocarcinoma, you see that it is more common in females. Squamous cell carcinoma is more common in male. Small cell carcinoma, again you see that the females are actually predominant. And large cell carcinoma according, but you see that the smoking maybe in Western countries there can be association with smoking or lung carcinoma in females. Usually these are peripheral locations. You see that this is a typical adenocarcinoma seen in the periphery. Any advantage that a tumor is seen in the periphery, resection is somewhat easy. Right? You can resect this part along with a very reasonable clearance with a normal lung tissue. And microscopically they form typical glandular pattern. You see that these are all adeno glandular pattern. So it's a well differentiated adenocarcinoma. This is actually a central lesion. You see the bronchus divided into the right and left. The principal bronchus is divided. This is the junction there with this lesion. The lesion is located as an exophytic lesion and slowly they are going into the luminal aspect. So after some time you see that the lining mucosa will get ulcerated. Any advantage, bronchoscopically you can get biopsies from here. It is visible, but an adenocarcinoma is never bronchoscopically visible because it's in the periphery, right? So a bronchoscope you can take a biopsy very easily from a squamous cell carcinoma. But resection is somewhat very difficult. You see that actually at the junction, resection is somewhat difficult. Any other advantage for diagnosis? You see the exfoliated cells may come into the bronchial lumina and this may come with sputum. So sputum cytology can be diagnostic sometimes in squamous cell. Any central lesion, this can be diagnosed, especially in the squamous cell carcinoma. This is the most non-invasive investigation, right? The sputum cytology. But the lung adenocarcinoma is usually diagnosed by fine needle aspiration cytology, a CT guided or even X-ray guided cytology can be done. This is the squamous cell carcinoma. You see that they are seen in lobules and you see the individual cell keratinization, very pinkish color keratin is there. So it is a very differentiated squamous cell carcinoma. This is again on the hilar aspect, but multicentric. You see that very dark hemorrhagic cells are there, hemorrhagic lesions are there, multicentric, multiple lesions are there, but hilar in location. And the microscopy they showed some lymphocyte-like cells. You see that they are actually cells, but what is happening to this cell? A lot of crushing is there, right? These are called crushing artifacts. Okay. Why there is crushing? The cells are so fragile. They are lymphocyte-like. Why it is lymphocyte-like? There is absence of cytoplasm. You see that cytoplasm is barely visible. Minimal amount of cytoplasm is there. The whole area of the cell is occupied by the nucleus and the nucleus has got a dark blue color. So this is again can be a DD for a small round blue cell tumor originally because the cytoplasm is not very striking. Why it is blue? Because the entire cell is actually represented by the nucleus and it has got a blue color. If it is actually the cytoplasm is reasonably abundant, in a squamous cell carcinoma it is not a small round blue cell tumor because you see it is somewhat pinkish in color, right? Because of the abundant cytoplasm. Okay. So what is this crushing? The cells are so soft and fragile when you cut with a microton knife. Because of the friction, many undergo crushing. This is called a crushing artifact. What is the significance of this? Suppose a pathologist sees a small cell carcinoma and he is not seeing any crushing artifacts. He is reacting to cyanotory report of small cell carcinoma because crushing artifacts should be brought to cyanotory report because it's a part of the game, right? So in inverted commas, I should say that artifacts can make real diagnosis. It's an artifact, not a real part of the tumor, but this makes the real diagnosis of a small cell carcinoma. For example, lacunar cells is not a true cell. The retracted cytoplasm is artifactual, but that makes the correct diagnosis of a nodular sclerosis Hodgkin lymphomas. Okay. So most of the, you see that the adenocarcinoma, the cytokeratin CK7 is positive, CK20 is negative, and TTF1 is positive. This is very important because TTF1 is again a very good marker for pathol carcinoma, thyroid carcinomas. Okay, suppose a thyroid carcinoma metastasis in the lung, again that can show a TTF1 positive. So what we will do? We will do a thyroid labeling immediately, and in a thyroid cancer that is metastasis in the lung, the thyroid labeling should be positive. In an adenocarcinoma in the lung, the thyroid labeling will be negative. Because you see that 5 to 10% of carcinomas are hidden occult carcinomas. You see that we get a lot of metastases, and I may say that 5 to 10% of the cases, even with all these modalities, the updated modalities, starting from CT to MRI, so many things are there. See, the primary carcinomas are still in occult. We can get this, especially in thyroid, pathol carcinoma. You see that it may be an occult carcinoma, may be give rise to a solitary nodule of thyroid. All the following are features of bronchoalveolar except. This is an important entity nowadays. Actually, it is a variant of adenocarcinoma, right? Acinar, papillary, BSC type. Bronchoalveolar is actually a variant of adenocarcinoma, but nowadays it is treated as a unique entity because of a unique clinical presentation, a unique histology, and a unique prognosis. Right? What is a unique presentation? Present as bronchopneumonia-like picture. We come across occasional case of BSC from the chest department, and most often the diagnosis may be a BSC, bronchopneumonia-like X-ray-wise with unique bronchopneumonia, multiple lesions involved in a lobe, sometimes a lobar pneumonia, sometimes a bronchopneumonia-like picture. Patient is given broad spectrum antibiotics, never respond to that. That is a history outcome. Has got a lipidic pattern. Very typically they have got a lipidic pattern. The tumor cells ultrastructurally similar to Clara cell, associated with stromal, vascular and prolongation. This is the wrong choice here. They are never associated with stromal, vascular and prolongation. There is less association with smoking because it's a part of adenocarcinoma. They show the nature, they are less associated with smoking. See, you see that you never think that it is a tumor, right? You see that this lobe is almost often affected. Majority of this lobe is affected, almost like a lobar pneumonia-like picture. And you never think that this is a tumor. This is a tumor. What is known as a bronchoalveolar. This is the lipidic pattern. You see that this is the normal lung tissue and this is the affected tumor part. You never get in any organ the affected tumor part never resembles the parental histology. You see that? Still, this is the tumor part. They mimic the typical alveolar pattern, right? Okay, suppose this part is not there, only this part is here, there only. Still, I should say it is an alveolar pattern is there. I cannot say it's a normal alveoli. It is actually the tumor involved alveoli, but alveolar pattern is well maintained. Never in a tumor you get this. It is an adenocarcinoma, you get only the carcinomatous part, and only if the normal tissue is not there in the adjacent part, then we cannot say it's a tumor of the lung or tumor of kidney or whatever it is. Okay, this is a peculiar thing. That is known as a lipidic pattern. And what is a lipidic pattern? Lipidic pattern is nothing but the butterflies are actually sitting on a fence. Okay, this is called a lipidic pattern. Similarly, you get the thing. You see that if you just imagine the butterflies are actually numerous numbers sitting on a fence, mimic the same pattern. That is what I say lipidic pattern. Very, very synchronous with the classical bronchoalveolar carcinomas. So, adenocarcinoma and bronchoalveolar carcinoma arises from tiny bronchioles and alveolar cells, and nowadays they say it is actually Clara cells and type 2 pneumocytes. The histogenesis, multiple histogenesis, they say it's actually from the terminal bronchioles, alveolar holes, Clara cells and type 2 pneumocytes. Distinctly gross and microscopic feature, present as bronchopneumonia-like, bronchoria, classically they are present as bronchoria with copious amount of sputum and lipidic pattern. And the two types of tumor is actually non-mucinous and mucinous. Non-mucinous and mucinous. Okay. What is the mode of spread of this non-mucinous? The mucinous is always aerogenous spread from one alveoli to the other. Right? Non-mucinous is actually not aerogenous. So the mucinous is usually presenting as a lobar pneumonia because it is aerogenous spread, one entire lobe may be affected. From one alveoli to the other, that is called an aerogenous. So it never have any vascular or lymphatic spread. It is aerogenous spread, that is important. You read it, Romans, it is actually a very important entity that is coming across. The mucinous BSC spread aerogenously forming satellite tumors, solitary or multiple nodules, entire lobule consolidated in lower pneumonia, the non-users can have peripheral nodule which is unable to, just like adenocarcinoma, because there is no aerogenous blood, unable to surgical excision. So the non-users has got a better prognosis. Overall, the prognosis is excellent. And it is said that the tolerance again is important nowadays. The paraneoplastic syndrome associated mostly with squamous cell carcinoma of lung rather than small cell carcinoma is a simple question. Just to discuss the various paraneoplastic syndrome associated with the bromogenous carcinoma, answer is hypercalcemia. Okay. So you get a list of paraneoplastic syndrome associated with bromogenous carcinoma. They produce ADH to produce hypernatremia, ACTH to produce Cushing syndrome, parathormone to produce hypercalcemia, calcitonin to produce hypercalcemia, gonadotropins to produce venocomastia, serotonin and bradykinin to produce carcinoid syndrome. Small cell carcinoma, they produce ACTH, that is Cushing syndrome, and ADH, that is hypernatremia. And squamous cell carcinoma, they produce hypercalcemia because of the parathormone elaboration. So the small cell carcinoma, it is Cushing syndrome and hypernatremia because of ACTH and ADH secretion, and squamous cell carcinoma, it is hypercalcemia. But rarely you can get hypercalcemia and even gynecomastia, and carcinoid syndrome is important especially for carcinoid tumors. What is the earlier terminology for carcinoid tumors in the bronchus? The carcinoid tumor, the pleomorphic adenoma, mucoepidermoid tumor or carcinoma. These three things can occur in the bronchus rarely. But the carcinoid tumor is very common, but the mucoepidermoid as well as pleomorphic adenomas are actually rare. Again, this can be a site in the bronchus. These three are called bronchial adenomas. Bronchial adenomas. Nowadays this terminology is not frequently used. Well, what is common to these bronchial adenomas? Hemoptysis. The classical presentation is hemoptysis. All these are characterized by typical hemoptysis presentation. So these are called bronchial adenoma. They are characterized by three tumors. The most common is carcinoid tumor, then pleomorphic adenoma and mucoepidermoid carcinomas of the bronchus. What is Lambert-Eaton myasthenic syndrome? They elaborate autoantibodies against the neuronal calcium channel and producing a myasthenia-like syndrome. A rare one, but this can be with bromogenous carcinoma. They can produce peripheral neuropathy, that is sensory, echindosis nigricans. Because you know the serious stomach is the most common cause for echindosis nigricans, but bromogenous carcinoma, again, any other tumor this can produce echindosis nigricans, we will come to that. Hematological abnormalities like leukemia reactions, hypertrophic pulmonary osteoarthropathy, and Horner syndrome, that is apical lung cancer, near superior pulmonary sulcus, invade the neural structure around the trachea, producing anastomoses, ptosis, meiosis, and fibrosis. And there are questions based upon this. The Horner syndrome is produced by this type, histological type of bromogenous carcinomas, squamous, not adeno, it is squamous cell carcinomas. So often you come across this term, small cell carcinoma versus non-small cell carcinoma. Because in cytology we often give this diagnosis as small cell, because cytology we get a few aspirate, few number of cells. So the classical, the pattern will not be seen, sometimes the horn tail will not be seen. So we say it's a small cell carcinoma versus non-small cell. The non-small cell includes the adeno and squamous. What is the significance of this? But the clinician is actually satisfied with this diagnosis in the cytology, the small cell versus non-small cell. Why the non-small cell is totally different from a small cell carcinoma? A small cell carcinoma means that it is almost like a death warrant to the patient. You sign out a report of small cell carcinoma, and you say that they never live beyond 6 months. It's a death warrant. In non-small cell carcinoma depends upon the stage of the disease. This can be a death warrant because the stage is actually very high. And this actually, there can be a lot of option for treatment. For example, small cell carcinoma, surgery is contraindicated. Because at the time of diagnosis, if they present with widespread metastasis. Right. But non-small cell carcinoma, according to the stage of the disease, the surgery is always indicated. Non-operable non-small cell carcinomas are there because they present as a higher stage. But according to the stage of the disease, otherwise, the single terminology of small cell carcinoma that keep away the sudden limitation because they never attempt any surgery for small cell carcinoma. But the chemotherapy, the small cell carcinoma, will mostly respond rather than the squamous cell and adenocarcinomas. You see that from the last one it is difficult, but this is again from rodents. Just go through this. It's a list of paraneoplasties. I will highlight some of this. Achilles negligence, gastric, lung and uterine cancer. Hyperglycemia, fibrosarcoma and hepatocellular. This is more common to present with fibrosarcomas. Sometimes the only presentation is actually hyperglycemic attacks, frequent hyperglycemia, because the tumor cells elaborate insulin-like receptors. Hypercalcemia, squamous cell carcinoma, lung, renal cell carcinoma, breast cancer, adult T-cell leukemia or lymphoma. What is it? It is human T lymphotropic virus type 1 induced leukemia or lymphoma. Sometimes they consistently present as hypercalcemia-like presentation. And ovarian cancer, mesothelioma, renal cell carcinoma, central hemangioblastoma, and hepatocellular carcinoma. It's nothing. You go through that table. It is actually everything is there. You get a lot of. And again, because you see that Achilles negligence. Again, all of the following are associated with Achilles negligence as a paraneoplastic manifestation, except the three tumors are there. And you may be aware of the first one really, maybe the brain carcinoma, but uterine carcinoma again is a third option. A 13-year-old male with a history of ulcerative colitis for the past 20 years is found to have a prostate stool gulk and a mass lesion is palpable with rectal examination. The lesion is probably long-standing ulcerative colitis. What is a complication? It is nothing but adenocarcinoma, especially for 20 years. You see the chance of getting so in ulcerative colitis we often get colonic biopsies or rectal biopsies, and see most of the ulcerative colitis can be clinically diagnostic. You see that it's actually the clinician can diagnose ulcerative colitis straight away by the investigation as well as the sigmoidoscopic examination. From the pathologists what they expect. For example, one is confirmation, second one more than confirmation. What is that? Activity of the disease. Because ulcerative colitis can have a quiescent phase as well as an active phase. Activity of the disease. What is the second thing? Level of dysplasia. Dysplasia is present. It is low grade, high grade. Right? Then obviously the carcinoma will come. And in long-standing ulcerative colitis, the carcinomatous complication we can actually even highlight it by the clinical history, because it may be minimum more than 10-15 years history will be there for a malignancy arising from an ulcerative colitis. So it's nothing but it is an adenocarcinoma. So ulcerative colitis is basically a mucosal lesion. You see that the mucosa, maximum to the submucosa is affected. Basically it is a mucosal lesion. It is a continuous lesion. While Crohn's disease is actually always a transmural inflammation from the mucosa to the serosa, and it is a skip lesion. It is discontinuous lesion. Some segment is affected, then you get a normal area, another segment is affected, just like that. Okay. And this is nothing but a crypt abscess. Crypt abscess is nothing but collections of neutrophils within the glands or mucosa. When you get collections of neutrophils, this is very, very important, because the crypt abscess tells the activity of the disease. Once you get mucosa, the neutrophilic collections in mucosa, it tells the lesion is very active. Okay. So crypt abscess are diagnostic as well as tells the activity of the disease. Global cell depletion is important. For example, this is actually normal area where you get diminishing number of globule cells, but here you see there is a marked depletion of globule cells. Okay, globule cell depletion is a feature you get. Okay. While the Crohn's you get you see that its stricture, its whole stricture, right? Crohn's is equal to stricture intestinal obstruction, right? So what is the common? It's tuberculosis. So we always have problem with tuberculosis based Crohn's. I think we underdiagnose Crohn's and overdiagnose tuberculosis. Because you get a stricture in the intestine, your diagnosis is always tuberculosis first, because it's so common here. And you see that your patient is treated with ATT and never respond to that, then only we think about the Crohn's disease. Okay. It is a transmural inflammation. You see the ulcer and you see the lesion up to the serosal margin. Often this is granulomatous, but remember that only 50% of the Crohn's is characterized by granulomas. Never all the 100%. Only 50% are actually is characterized by granulomas. So even you can get non-granulomatous lesions in Crohn's. So you get the tables and ratings, not from the present ratings, I think in the previous. You see that I want to highlight some of the points. You see that the Crohn's can affect the small intestine as well as the colon, the large intestine also. But ulcerative colitis is colon only. Only large intestine. Skin lesions is a part of Crohn's, but it is a diffuse lesion. Stricture is very, very invariably associated with Crohn's, but stricture is extremely rare in ulcerative colitis. Instead you get the opposite thing, you get dilatation, that is known as toxic megacolon. You get. Whole appearance is thickened and very thin, and dilatation is actually obviously not a part of Crohn's, but it is a part of ulcerative colitis. Inflammation is transmurally limited to mucosa alone. Pseudopolyps is a feature of ulcerative colitis. Ulcers are deep and linear and very superficial in ulcerative colitis. You get fibrosis. Stricture is a feature of Crohn's, but never a feature of ulcerative. And granulomas we get only in 50%. And fistula and sinuses can be a complication, never a complication of ulcerative colitis. The response to surgery is very poor in Crohn's and excellent in ulcerative colitis. So, IBD associated neoplasia, the risk increases sharply 8 to 10 years after disease initiation. The usual time is around 10 years. Then again you see that they start with dysplasia sequence, then go for carcinoma. Patient with pancolitis has got a higher risk than those with left-sided disease of ulcerative colitis. Low-grade and high-grade dysplasias are there. So the pathologists are actually asked to comment on the level of dysplasias. If it is present, whether low-grade or high-grade. Ulcer-inflammatory lesion limited to colon affects only mucosa and submucosa, extends in a continuous fashion proximally from rectum. And you can get other systemic autoimmune disorders associated with ulcerative colitis are migratory polyarthritis, sacroiliitis, radiation spondylitis, uveitis, and primary sclerosing cholangitis. I think this question may not be there. Hygienic hypothesis is suggested etiology of. Yes, it is inflammatory bowel disorder. This is a theory that is nowadays there. Okay. I think when you do this search, you can get an article, a New England Journal. You see that medicine. You see that eat dirt and keep away from inflammatory bowel disorder. So the hygienic status is actually increasing, and we are getting a lot of inflammatory bowel disorders nowadays. So this is called the hygienic hypothesis. So what happens? IBD incidence worldwide is on increase, more common in regions of Africa, Asia and South America, where the prevalence is low historically. See, I think maybe 20 years back we actually come across very less number of inflammatory bowel disorders, because the hygiene is actually less. We get more of parasitic infestation. You see that when I was a household, we think about the piperazine citrate and all that is given to you get clusters of worms will be passed by the children, and it's very common. Nowadays it's not there, right? So the hygienic aspect is actually increased, so we get this sort of infection. In this this incidence is related to improved food storage condition and decreased food contaminations. Okay. This hypothesis suggests that reduced frequency of endemic infection has resulted in inadequate development of regulatory process to limit mucosal immune responses. So what happened? You see that because of the hygiene, the endemic infection is actually reduced. So this has resulted in inadequate development of the regulatory process to limit mucosal immune responses, allowing the pathogens that cause self-limited disease to trigger autoimmune immune responses and chronic inflammatory. Just remember that this is a theory nowadays. It's actually established theory and it's a proven one beyond doubt. All of the following are true regarding angiodysplasia except occur most often in cecum or right colon, most common in the second decade of life, characterized by malformed submucosal and mucosal blood vessels, and presents as episodes of lower intestinal bleeding. Cecum or right colon is not the correct site. See, angiodysplasia always involve the cecum and right colon. But this is actually in the 5th or 6th decade people you get this angiodysplasia, not in children. You see that occur after the 6th decade only. The submucosal vein occlusion lead to focal dilatation and tortuosity of the overlying submucosal and mucosal vein that trigger the problem. So it's basically a submucosal vein occlusion, which leads to the focal dilatation of the intestine, dilatation and tortuosity of the overlying submucosal and mucosal vein that trigger the problem. So basically the site that is affected, only two sites, it is cecum and right colon. Most common occur after the 6th decade of life and characterized by malformed submucosal and mucosal blood vessels present as episodes of lower. See, it is said that 20 to 30% of lower GI bleed is due to angiodysplasia. According to Roberts, 20 to 30% of lower GI bleed is due to angiodysplasia. We will read that because I have seen this question not in this way, but you see that these rare things. So according to the UG level, I don't think that angiodysplasia, the pathology, all these things are important, but you get questions like this. But this is actually the everything. Because the basic question, most of the students will answer, and you see that this is actually the difference between a good student and actually an average student. So it is occurred after 6th decade. A patient underwent a colectomy and over 200 adenomatous polyps are present on gross examination. He could have any of the following condition except. So what is your diagnosis? Familial adenomatous polyposis. Why it is familial adenomatous polyposis? More than 100 adenomatous polyps is enough to make a diagnosis of FAP. Right? It is a typical autosomal dominant disorder. It is a prototype autosomal dominant disorder that is equal to FAP. Gardner syndrome is the variant of FAP. Proves that it is characterized by hamartomatous polyps, never by adenomatous polyps. Proves that is nothing to do with FAP because they are characterized by hamartomatous polyps. What is the significance of hamartomatous polyps? They are never be precancerous. Hamartomatous polyps are just inflammatory polyps. It is actually not inflammatory because it's actually hamartomatous, but they are never associated with a precancerous etiology. High risk for colonic carcinoma. What is the risk? How much percentage? 100%. I should say that the risk is 100% for the patient and not for the polyps. All the polyps have never become malignant. At least one of the polyp in the patient will become malignant at the age of 30 or 40. So the incidence of malignancy is 100% for the patient and not for the polyps. How many polyps usually you get? It's said to be 500 to 1500 or 2000 polyps. even though 100 is actually the cutoff, you often get more than 500 polyps in the FAP. And onset of the disease and adolescence is right. You see, these are the polyps, very typical polyps. You see, number of polyps are there. This is the normal mucosa and this is the lining mucosa of the polyps. What is the difference? This look more bluish, right? Right? And you see that there is a single line of cells here. You see it's line. And there is some area there is stratification because you see that this is folded and when you cut this you get multiple layering. This is actually an artifactual thing, not assembly, because when you fold you cut it, you get multiple cross sections of the nucleus. But here it is actually multicentric, right? More than, you see, entire lining cells is actually showing nucleus, right? Again you see the glands again you see that the chromatin content of the nucleus is more. What do you call this? Dysplasia. This is dysplasia. So adenomatous polyps is always lined by dysplastic mucosa and not by a normal mucosa. Okay. So how do you classify the small intestine colonic tumors? Non-neoplastic polyps or hypoplastic polyps? Hematomatous polyps can be juvenile and pure sugar. Juvenile and pure sugar. Inflammatory polyps are there, lymphoid polyps are there. Remember that the juvenile polyps, even though they are hematomatous polyps, in juvenile polyposis syndrome, there is a mild risk for malignancy. Right? Juvenile polyposis syndrome. But individually, juvenile polyps never become malignant. In pure syndrome, they are classically hematomatous polyps. They are never show any malignant features or dysplasia. But in pure syndrome, there is actually incidence of extra GAT malignancies. The polyps never become malignant, but you can get extra GAT malignancies in juvenile pure syndrome. This is again from rabies. You see that this is the classification of the hereditary syndrome involving the GAT. FAP is divided into the classic FAP, where we highlight all the points. Then attenuated FAP. What is that? Attenuated FAP means that they will be characterized by few number of polyps less than 100. And the incidence of malignancy is only up to 50%. That is called attenuated FAP. They are typically adenomatous polyps, but the number of polyps are not 100, maybe below that, and the incidence of malignancy is just 50%. And Gardner syndrome is a variant of FAP, and Turner syndrome is again a variant of FAP. Pure sugar, you see STK11 gene is characterized by hematomatous polyps. Juvenile polyposis syndrome, it is SMEB4 and BNPRI, this is the altered gene, and characterized by juvenile polyps. HLBCC, defects in mismatch in DNA repair gene, that produces a colony. So what is the mechanism of HLBCC? That is known as Lynch syndrome. This is actually discovered by Dr. Lynch, LYNCH. It is called Lynch syndrome or HLBCC. What is the mechanism? Microsatellite instability. Microsatellite instability. This is characterized by non-polyposis. There is no polyp, but there is colonic carcinomas. Then tuberculosis, it is characterized by inflammatory polyps. Connons, it is the PTEN gene, is characterized by hematomatous polyps. Hematomatous polyps. Okay. So, FAP syndrome is the archetype of the anomalous polyposis syndrome. Mutations in anomalous polyposis collagen, there is APC gene on chromosome 5q21, classic attenuated Gardner and Turner syndrome. Minimum 500 to 2500 polyps usually, but 100 is cut off. Attenuated fewer polyps located in proximal colon and cancer risk is just 50%. Pure syndrome, hematomatous polyps. Autosomal dominant, multiple hematomatous polyps in the entire GAT, melanotic mucosal and cutaneous pigmentation, the circumoral pigmentation, and even in external genitalia. You see that the mucosal pigmentation, The meiotic mucosal and cutaneous pigmentation that is subcumorally or in the external genitalia, no malignant potential prone for intussusception only. Modest risk for extra-GAT cancers in placenta, but the polyps have never become malignant. HLBCC, autosomal dominant, is called Lynch syndrome. Risk for colorectal cancer, endometrial carcinoma, urothelial carcinoma. Mutations in DNA repair gene leading to microsatellite instability is actually an important feature. What is Gardner syndrome? It is a variant of FAP characterized by multiple osteomas of the mandible, skull and long bones, plus lot of cyst, epidermal cyst and fibromatosis, risk for duodenal and thyroid cancer. Parker syndrome, it is adenomatous polyposis along with CNS lesion. That is tumors of CNS in the form of medulloblastoma and glioblastomas, right? Okay. Following are related to sinonasal papilloma except caused by HPV 16 and 18, many neoplasm, high potential for engagement of the ovary composed of squamous cells. It is HPV 6 and 11 are associated, just like chondroblastoma accumulating, not 16 and 18. It is a classical neoplasm. You see that caused by HPV 6 and 11 like chondroblastoma accumulating occur in three forms. Exophytic, that is the most common. Inverted, that is actually, this is, inverted is actually more important because of the biological behavior in cylindrical. Inverted papillomas are benign but locally aggressive, occur in both nose and the paranasal sinuses. They are benign neoplasm, but you see that locally invasive. You see that sometimes the orbital part is involved and very locally aggressive one, but they are benign, locally invasive, locally aggressive, involving the nose and the paranasal sinuses, and they are composed of squamous cells. Okay. So this is a Barrett's. So Barrett's diagnosis is a histological diagnosis? No, it is an endoscopic diagnosis. Barrett's diagnosis is always an endoscopic diagnosis, and histologically what I said again highlighted is actually the level of dysplasia. And they measured how much areas of the lesion is there. It is actually whether it is more than 2 cm or not. You see that this is nothing but this is a metaplastic columnar epithelium. This is the lower end of esophagus, and here this part is actually undergoing metaplasia, columnar metaplasia. Not the esophageal gastric junction, that is very important. By location wise, they can say that it is not the esophageal gastric, because some may say that if this is esophagus and this is the gastric junction. So how I should say that it is actually endoscopically they can decide it is the esophageal gastric junction or not that. So they measure this and say that this is actually 40 cm or 35 cm, and this is actually the area where you get the metaplasia of the lower end of esophagus, and then you can get the columnar lines, and there is mild dysplasia of the column. It's not darkish. It's only a very low grade dysplasia seen here. More than 2 cm gastric mucosa, 30 to 40-fold increase in development of malignancies. Early gastric carcinoma is best described by, characterized by. What is the definition of BGC? That is itself is a question. Early gastric carcinoma is equal to a carcinoma limited to mucosa and submucosa. What is the next thing? Regardless of the perigastric lymph node involvement. That is very important. Any other lymph node, it is advanced, right? Only perigastric lymph node involvement. If the lesion is limited to mucosa and submucosa, even if the perigastric lymph node show metastasis, it is early gastric carcinoma. But outside that, any lymph node invasion, it is actually an advanced stomach. Early gastric carcinoma is a lesion confined to the mucosa and submucosa, regardless of the presence or absence of metastasis to the early gastric lymph node. The definition itself has been asked for different choices. Advanced gastric carcinoma is a neoplasm that is extended. So when you say it's a CS stomach, it is equal to advanced gastric carcinoma. We never say that it is an advanced invasive CS stomach. The CS stomach means that it is an invasive CS stomach. The neoplasm has extended below the submucosa into the muscle layer. Okay. So what is the answer? A 5-year survey following resection more than 90% of nowadays. We usually never come across EDC because our patient used to present with an advanced CS stomach. Okay. So EDC diagnosis is actually pretty limited to Japanese people because you see that the incidence of CS stomach is so high there. So almost every employee is actually worked in reputed companies. They with some history of reflux esophagitis or dyspepsia or something like that, heartburn. They underwent this endoscopic examination once in a year, and you get this diagnosis in these patients with an excellent prognosis. And signaling by light microscopy and the gross appearance of we will come across that. So the gastric carcinoma, you see that you can have a break now, 10 minutes, right? regarding the carcinoma stomach, what are the gross types of CS stomach? The morphological types of the gross types, it is excavated, flat or depressed, exophytic and limit is plastica. See, the exophytic gross type is actually they present with an exophytic lesion that is projecting into the lamina or raised lesion, and the excavated you get it's a shallow or deeply erosive crater which can mimic a chronic peptic ulcer. So here excavated lesion mostly difficult to differentiate from a chronic peptic ulcer. Then you can get flat or depressed lesion without any no obvious tumor mass. And limit plastica is nothing but an extensive infiltration of the entire wall of the stomach by the malignancy, that is known as leather bottle stomach or limit plastica. What are the microscopic types of CS stomach? It is the intestinal type and the diffuse infiltrating type. Intestinal type, they always associate with chronic gastritis and intestinal metaplasia. They are associated with H. pylori infection. A chronic H. pylori infection producing a chronic gastritis. A chronic gastritis is nothing but they are always associated with intestinal metaplasia. This will be a pre-runner for the intestinal type of stomach cancer. Here, in this type of stomach cancer, the tumor cells are represented by intestinal type of glands. The tumor cells tend to form glandular pattern mimicking intestinal type of glands. That is why it is called intestinal type. So when you get an intestinal type of gastric cancer, you think about a H. pylori infection, a chronic gastritis and intestinal metaplasia. The second one is called diffuse infiltrating type. They are never characterized by H. pylori infection. They are never characterized by chronic gastritis or intestinal type of metaplasia. Here the tumor cells, they form sheets without any glandular pattern. Even though any CS stomach is adenocarcinoma, the glandular pattern will be lacking in diffuse infiltrating type. The two best example of diffuse infiltrating type is a sigmoid cell carcinoma as well as a limb plastica or what is equal to a leather bottle stomach. Which is the most favored location for a gastric carcinoma? It is lesser curvature, andro-pyloric region. Because pylorus and andrum, they represent 50 to 60% of cases, cardia only 25% of cases, the body and fundus the remainder. Lesser curvature 40%, greater curvature 12%. So the most favored site is actually andro-pyloric region, lesser curvature, and this may be again the favorite site for a peptic ulcer also. All of the following are true of nasopharyngeal carcinoma except distinctive geographical distribution. Yes or no? Yes. Where you get? Southeast China you get. And classically said to be in woodwork case, you get the nasopharyngeal carcinoma. Histologically syncytial pattern. They are adenocarcinoma, rich lymphocytic infiltration. They are always squamous cell carcinoma. They are actually poorly differentiated squamous cell carcinoma. Okay. Never be an adenocarcinoma. Histologically, there is a classical syncytial pattern and characterized by rich lymphocytic infiltration. They can be keratinizing squamous cell, non-keratinizing squamous cell and undifferentiated. So anyway, it is squamous cell carcinoma. And what is meant by a syncytial pattern? Syncytial pattern means that there is a individual cell bodies, the cytoplasmic bodies will not be clear. Individual cell cytoplasmic bodies will not be clear. Usually you see that the individual cell bodies may be clear and you can see that this is one cell, the other cell is actually this. Here you see that the entire cell is actually pooled together and you get a pool of cytoplasm where in which you get the regularly arranged nucleus. Okay. So individual cell bodies may not be clear. That is called as syncytial pattern. So here you get a syncytial pattern with a very rich lymphocytic infiltration that is equal to a nasopharyngeal carcinoma. 30-year-old male presented with persistent cough, hemoptysis, intermittent diarrhea, flushing and cyanosis. So it is clear. What is it? Carcinoma syndrome. Endoscopic study revealed a spherical polypoid mass in the bronchial lumen confined to the mainstem bronchus. Following statement regarding this lesion are true or false. Lesion is neuroendocrine in origin. Yes. So list out the neuroendocrine tumors. What are they? Classically, the neuroendocrine tumors are actually neuroblastomas or neuroendocrine, then Ewing sarcomas. Typically it is neuroendocrine, then leukocytomas, paragangliomas, they are neuroendocrine, carcinomas are neuroendocrine, medullary carcinoma thyroid, small cell carcinoma of the lung, all are neuroendocrine. It is neuroblastoma, then medulloblastoma is a neuroendocrine tumor, Ewing sarcomas are neuroendocrine, then you see the carcinoma tumor, leukocytoma, paragangliomas, medullary carcinoma thyroid and small cell carcinoma. Typically the small cell carcinoma they arise from Kuchinsky cells. Kuchinsky, that is said to be, again the carcinoma tumor is said to be arise from Kuchinsky cell, that is endochromaffin cells. That is actually a neuroendocrine origin. And lesion is classified as typical and atypical. The carcinoma is always classified as typical and atypical type of carcinoma. In the bronchus typically present as collar button lesion, that is again a true statement, and that is known as a bronchial adenoma. Ultrastructurally, cell showing tone of filament is not correct. The tone of filaments are usually for a squamous cell carcinoma. Carcinomas, never for a neuroendocrine carcinoma. Any neuroendocrine cancer is characterized by membrane-bound, dense core secretory granules. Membrane-bound, dense core secretory granules. Any neuroendocrine tumor, starting from carcinoma to anything, may be benign or malignant, they are characterized by membrane-bound, dense core neurosecretory granules. So, ultrastructurally, they show tone of filament is not correct, and you see that the rest of the things can be, you can take this as true, and histologically they are classified as typical and atypical, that is again a true statement. And you know the most common site of carcinoma tumor is actually bronchus. Okay, bronchus is the most common site. Coming to the GET carcinoids, you see that the GET carcinoid, the most common site is ileum. Ileal carcinoids are the most common, followed by appendix and recta. For any ileal carcinoid, you see that to present as carcinoid syndrome, for any GET carcinoid, what is the minimum requisites? Liver metastasis. But this is not true for any respiratory bronchial carcinoids or something like that. Any GET carcinoid, to produce carcinoid syndrome, the minimum requirement is actually a hepatic metastasis. Okay. So which is the common GET carcinoid that is producing carcinoid syndrome? The choices were ileum, then appendix, rectum, and any other site in the GET. Why ileum? Ileum is the correct answer. Why? Ileal carcinoids can present as, because the rectal and appendiceal carcinoma, that is the appendix, I think the second most common site for GET carcinoids apart from ileum, and the third one is rectal carcinoids. They almost never metastasize. The rectal and appendiceal carcinoid, they almost never undergo metastasis. So there is no chance for any carcinoid syndrome, right? Only ileal carcinoid, they produce carcinoid syndrome. So the carcinoid syndrome is due to 5-hydroxytryptamine, that is serotonin elaborated by the tumor cells. What happens to this 5-hydroxytryptamine? They are converted into an inactive compound that is known as 5-hydroxyindole acetic acid, 5 that is the hepatocytes. Whenever there is a liver metastasis, the liver function is getting compromised and this conversion is not taking place. So the active compound will remain as phosphatidyltryptamine and this produces carcinoma syndrome. So that is the mechanism. So this statement regarding small intestine carcinoma tumor is incorrect. They may produce gastrin, but still majority of them are histologically malignant. The carcinoma syndrome usually occurs in liver mets. That is a true statement. The non-partial cell may contain neurosecretory granules. See, majority of them are not histologically malignant. But you see a significant number can be histologically malignant also. But you see that the appendiceal and ductal carcinoma, you see that they are asking about the intestinal carcinoma. So it's predominantly it's the ileal carcinoma that is important. And ileal carcinoma can be malignant, but most of them are not histologically malignant. The sign of malignancy regarding the carcinoma is actually you get increased mitotic rate, cytological OTPA as well as metastasis. This is a carcinoma. You see the typical trabecular pattern of a carcinoma, misting trabecular pattern. A 34-year-old man has malabsorption. The jejunal biopsy shows flattening of window with diffuse centritis. What is it equal to? When you get flattening of window with diffuse centritis of jejunal, it is equal to a serious or gluten-sensitive neuropathy. So, answer is definitely a gluten-free diet here. The flattening of window with diffuse centritis, that is the pathological finding you get in the serious group. You see that this is the jejunum. A jejunal villi is always leaf-like villi. Typically you get leaf-like. It seems as a leaf, the shape of a leaf. But you see, totally flattened, right? This is the affected part and there is no villi at all. Flattening of villi and the inflammation is actually from the mucosa to the serosa, what is known as diffuse enteritis. The gluten sensitive enteropathy, that is serious one, sensitivity to gluten, which is alcohol soluble, water insoluble protein, and usually a component of wheat and closely related grains like oat, barley, and rye. The small intestinal mucosa, when exposed to gluten, they recruit or accumulate intraepithelial CD8 T cell and large number of lamina propria CD4 T cells. So when they are exposed to gluten, they recruit or accumulate the CD8 T cell and CD4 T cells. There is a marked link to HLA. HLA DQ, class 2 HLA, that is HLA DQ2 or DQ8. Very strong association, HLA linked. HLA DQ2 or HLA DQ8. Usually the gliadin that is contained within the gluten is deamidated by the enzyme transglutaminase. And the deamidated gliadin particle, they bind to this HLA. The deamidated gliadin particle, they binds to this HLA DQ2 and DQ8. And this complex of deamidated gliadin with HLA complex are recognized by the CD4 T cell, and the CD4 T cells may get stimulated and they secrete lot of interferon which damages the mucosa. So that is why you get a flattening of the villi. The mucosa is getting damaged by the interferon that is secreted by the CD4 T cells after the recognition of this HLA with the deamidated gliadin particle. What are the modalities of investigation? Anti-gliadin antibodies, anti-endomysial antibodies. These are the two important investigation. You can get actually anti-gliadin antibodies and anti-endomysial antibodies. Where you get anti-endothelial antibodies? Anybody? Could be vasculitis, right? Anti-endothelial antibodies. Which vasculitis? Kawasaki disease. Typically in Kawasaki. That is again being a question. Anti-endothelial antibodies are suggestive of Kawasaki disease. the long-term complication of serious pain? The long-term complication is actually a post-spore associated T-cell lymphoma. This is the only T-cell lymphoma occurring in GIT. All others are B-cell lymphomas, starting from martomas, mantle-cell lymphomas, then you get the Burkitt lymphoma. All are B-cell. This is the only T-cell lymphoma occur as a complication due to that is due to SLSP, that is post-spore associated T-cell lymphoma, and there is less chance for other malignancies like small cell adenocarcinoma and esophageal squamous cell carcinoma also. So, IgA antibodies to transglutaminase, IgA or IgG antibodies to deamyloid and anti-endomycin antibodies all can be the investigation of choice. Okay. Seen by colonoscopy in a 41-year-old male has 1 centimeter polyp on the neurostome that is located in the visiting colon. Microscopically there is crowded tubular atypical colonic glands in this polyp. The best diagnosis is the middle-aged man. Actually, a polyp is located in the descending colon. The polyp actually is excised and microscopically they are composed of crowded tubular atypical colonic glands. And what is the diagnosis? Epidermolysis bullosa. Why? Dysplasia. Atypicality, crowding, all are actually signs of dysplasias. So, inflammatory fibroid polyp, you get only inflammation and fibrosis. P7 polyp is hematomatous polyp. So, what is the normal histology of a P7 polyp? The muscularis mucosa, they show a tree-like branching. They branch and each branch, they go to the mucosa. Okay. These are the muscularis mucosa, they branch in various, in one direction and go to the mucosa. Individual mucosal area, you see this branch of muscularis mucosa is going. And typically, that is a tree-like branching of muscularis mucosa. That is spring-checker. Ulcerative colitis, you get only pseudopolyps. And hyperplastic polyp, you get, it's a very usual. That is maybe the commonest polyps, maybe hyperplastic polyps. It is actually an exaggeration of the mucosal glands, but there is no dysplasia, no inflammation. Any adenomatous polyps are divided into tubular adenomas, villous adenoma and tubulovillous adenoma. If the polyp, you see 75% of the area of the polyps, they are composed of glands, tubular glands. It is called tubular adenoma. If there is no tubular glands, predominantly it is a villous architecture, it is called a villous adenoma. If you get a mixture of tubules with villous architecture, it is called tubulovillous. So any adenoma should be actually reported as tubular villous or tubulovillous adenoma, because you see that the percentage of malignancy in a villous adenoma which measures more than 4 cm, it is 40%. So beware of villous adenomas. Tubular adenomas are not that much dangerous. But when you get a villous adenoma, especially the measurement is more than 4 cm, grossly, you see that the chance of getting a complication of adenocarcinoma is very, very high. It's around 40%. This is a polyp. You see that this is a polyp. It's a sessile polyp, not a polyp polyp. You see that this polyp, you see the upper part of the polyp, this is lined by the mucosa, this is the normal colonic mucosa here, and this is the exophytic growth of the polyp. You see, here it is dysplastic, right? They are more bluish, crowded, you see the glands here and you see the glands here. So this is a typical adenomatous polyp. We should say it's a tubular adenoma because they are composed of tubular glands. So sometimes the polyp, you see that there can be ulceration as well as malignant change. Could be these are actually malignant change occurring in polyps. This is nothing but this is the villous architecture, right? Very broad mushroom surface. You see, this is the villous architecture. Villous architecture has got a flat surface, and you see the villous architecture, very complex arrangement, absolute absence of tubular glands. There is no tubular glands at all. So this is called a villous adenoma. Villous adenomas are more dangerous than tubular adenomas. This is a very simple question. The salivary gland tumor with strong tendency to invade the carcinoma, what is known as the perineurial infiltration. Tell me two other common tumors which can have a perineurial infiltration. Or if you got an exception, there may be three choices which can have a perineurial infiltration with an exception. Okay. Because the choices are commonly these four. So two more tumors are there with perineurial infiltration, and they are pancreatic adenocarcinoma and prostatic adenocarcinoma. Okay. You see the pancreatic adenocarcinoma and prostatic adenocarcinomas. So what is the significance of perineurial infiltration? They produce the extreme pain, right? That is why the pancreatic carcinomas are extremely painful. Once you get a perineurial infiltration, you get the heights of the pain you get. Okay. And acidic cell carcinoma, mucoepidermal carcinoma, cystic carcinoma, malignant neuroepithelioma, all actually salivary gland tumors, which is the most common salivary gland tumor. Mucoepidermal carcinomas. Most common is mucoepidermal carcinoma, that is the most common malignant salivary gland tumor. Which is the commonest salivary gland tumor? Pleomorphic adenoma. No doubt it is pleomorphic adenoma. Cystic carcinomas are very common in minor salivary glands. Minor salivary glands. Not in major salivary gland, it is much more common in minor salivary glands. I should say that actually the incidence is actually inversely proportional to the size of the gland. Incidence is more in smaller glands. Okay. The single most common site for adenocystic carcinoma is, altogether it is minor salivary gland. Minor salivary glands we get in a lot of regions, right? Palate is the single most common site for adenocystic carcinoma. If the choice doesn't contain palate, it is actually minor salivary gland, definitely that should be the answer. If palate is given as a separate choice, you should go for that. Okay, this is the histological classification. You see the pleomorphic adenoma, 50%. Malignancy, the most common is mucoepidermal carcinoma, adenocarcinoma not otherwise specified, acidic cell carcinoma, adenocystic carcinoma, malignant mixed tumor, 3 to 5%, squamous cell carcinoma, and other carcinoma. Okay. Then oncocytomas is 1%. It's a benign tumor. What are oncocytes? Any cell which has got a rich mitochondria is called oncocyte. A cell rich in mitochondria. Suppose a cell is rich in mitochondria, in HND wise, staining wise, what is the appearance of that? They have a brightly eosinophilic appearance. Brightly eosinophilic granular, very outstanding cell. A bright eosinophilic granular cytoplasm. And itself says that this has got a rich mitochondria. The best example is a Herpes cell is actually a cell with a rich mitochondria that is actually an oncocytic type of cell. Sometimes you get oncocytoma, which is arising composed of oncocytes, that is equal to a benign neoplasm. What are the three sites, common sites for oncocytoma? Yes, it is salivary gland, thyroid, renal, and generally parathyroid. Renal, you get, it's again not an uncommon site for oncocytoma. Renal oncocytomas. What is the gross appearance of renal oncocytoma? Again there is a question. On cut section they show a central scarring. It has got a mahogany brown appearance. A tumor is renal oncocytoma. A renal tumor with a central scar with a mahogany brown color, it is renal oncocytoma. And the fourth site is parathyroid. So thyroid, salivary gland, renal, and parathyroid. It's totally a benign tumor. This is Warthin's. You see, this is a adenocystic carcinoma. You see that, what is this pattern called? Histological pattern in adenocystic carcinoma. Because carcinomas and some malignancy has got a pattern. You see that pathology is almost purely morphology. Nowadays, we come across all sort of molecular things for confirmation and all that. But basically it is a morphological aspect. You see that this is almost like a picture, and you see that by looking into your photograph, and I am saying that this is this. Okay. So you see that this is called a cribriform pattern. Cribriform pattern. Okay. A cribriform pattern. And cribriform pattern is always for a carcinomas. And other carcinomas where you get a pulmonary infiltrations, pancreatic and prostatic carcinomas. Histological feature indicative of worse prognosis for mucoepidermal carcinomas. Earlier, maybe the previous editions or organs, you say it is mucoepidermal tumor. They don't call it a carcinoma. Nowadays, we know that it is all carcinoma, but this low grade and high grade is there. There is actually three varieties: low grade, high grade, and intermediate grade. The question is that which indicates that it is a high grade mucoepidermal carcinoma. That is the question. It's nothing but lot of squamous component is there. It is high grade. If you get lot of adeno component is equal to mucin, right? If the tumor contains lot of mucin also, it is low grade. If they contain both, it is intermediate grade. Because it's important, because mucoepidermal carcinoma, even though all are invasive carcinomas, majority of them can behave as a low grade according to the components. If solid component is, the squamous is always called solid, because its solid component is more, it is high grade. If adeno or mucin component is more, it is actually low grade. So this is low grade, the first one. This is intermediate grade because both are there. This is high grade, and again this is low grade. 15% of salivary gland tumors, 60 to 70% are seen in parotids. Most common primary malignant tumor of salivary gland, low, intermediate, and high grade. One neoplasm which is seen most of exclusively in parotid is Warthin's, right? Because in myocellular gland we never give a diagnosis of Warthin's. Warthin's is almost exclusive to parotid. Not any other site we give the differential diagnosis as Warthin's, because it is extremely rare and almost unknown in many other salivary glands apart from parotid. Ulcer of intestine which is transverse in alignment. One is tuberculosis. Typhoid it is longitudinal. Crohn's it is linear serpentine. Ulcerative colitis it is very, very superficial ulcer. Ulcerative colitis it is superficial. Typhoid it is actually longitudinal. Tuberculosis it is transverse. Crohn's it is actually linear serpentine. And anemic it is flask shaped. Why the tuberculosis it is transverse? They involve the lymphatics, and lymphatics are arranged circumferentially. And why in typhoid they are longitudinal? They involve the Peyer's patches, and Peyer's patches are arranged longitudinally. Okay. And which often producing perforation. It is typhoid, not nowadays. You see that nowadays you see that it is antibiotics are actually used, and you see that typhoid ulcer is actually there is impending perforation is actually very less nowadays. Tuberculous ulcer they produce a lot of stricture, fibrosis, so there is no chance for tuberculous ulcer perforation. Crohn's again less chance. Ulcerative colitis actually they are not very true ulcer, they are very superficial ulcers. So these are the different ulcers you get in intestine. This may be a surgery question. The commonest type of atresia and pectoesophageal fistula is in the question. Actually it is called type C, upper blind and lower with trachea. This is the common one. Upper is blind, lower communicates with the trachea. Type A, both are blind. Type B, you see the upper is there only and they communicate with trachea. And here you see that the lower communicate with the trachea and upper is blind. This is the common one. And here the upper is blind, they are not communicating with trachea. And here it is anastomos, anastomosing. Glycogen storage disorder associated with cirrhosis is one jerking is type 1. It is called hepatomegaly. Even though it is called hepatomegaly, they present with lineomegaly and hepatomegaly, they never present with cirrhosis. This is type 4. It is actually Anderson. So the only glycogen storage disorder associated with cirrhosis is type 4. That is Anderson. Type 2 is Pundis. What is the significance of Pundi? This is the only lysosomal disorder coming under the glycogen storage. This is the only glycogen storage disorder coming under the lysosomal storage disorder. Rest are not lysosomal. And they present with cardiomegaly. Basically with cardiomegaly. And here we usually do the POS with without bystanders. That is actually very important. Some questions were a single question. The organ that is most frequently activated in the carcinoma. Simple RAS mutations. Any adenocarcinoma, I should say that more than 80% or 90% of RAS mutations are there. It is RAS. Nick is an organ where that three nicks are there. C-nick, Y-nick and N-nick. C-nick is a translocation in buckets 814 and N-nick is an N-nick or amplification. See, N-nick in neuroblastoma, N-nick in small cell carcinoma. Yeah. Okay. What is actually in breast cancer? You see that this is for name from Gordon. So according to the type of mode of activation, what are the mechanism of mode of activation for a oncogene? I should say that there is overexpression is there, gene mutations are there, and translocation is there, amplification is there. But one mechanism is not there, which is an exclusive mechanism of tumor suppressor gene. That is known as deletion. Any tumor suppressor gene is actually, the only mechanism is deletion. Remember the RB gene. When RB gene is getting deleted before birth, what is known as the double hit theory or nuts hypothesis. So one mechanism by which the oncogenes are not activated is deletion. And deletion is a pure business for tumor suppressor gene. Okay. And this table is again very important table. L-nick seen in small cell carcinoma, and C-nick is translocation, N-nick is neuroblastoma. How this amplification mechanism is actually by calibrating. What is the method by which we can actually use this amplification? Nowadays you see that this technique is not being employed, but rodents it is giving, I think it's a picture is there in rodents. What is known as the double minutes? You have a double minute, M-I-N-U-T-E-S. Double minutes and one more thing. That is actually a sign of amplification seen as a therapeutic mechanism. Nowadays is actually an absolute one. Which one of the following tests is inappropriate in the diagnosis of a patient suspected of having chronic active hepatitis? A logical question, simple one. What is the answer? Anti-hepatitis A antibody. Hepatitis A never become chronic hepatitis, right? So any chronic active hepatitis, you see hepatitis B virus infection, that is one of the most common cause. Secondly, hepatitis C virus infection, that may be the predominant cause for a chronic hepatitis nowadays. And usually with a chronic active hepatitis, liver biopsy is always indicated. So it is an A. Features of recent disease include all of the following except elevated cellular interference, acute hemolytic episode, cirrhosis, and elevated hepatic copper levels. Answer is elevated ceruloplasmin because they are always characterized by low serum ceruloplasmin level. Care films are clinically very important. They can present with just acute hemolytic episodes. Cirrhosis is a complication of Wilson's disease. And what is the diagnostic criteria? Hepatic copper index. It is called hepatic copper open, they combine with alpha-to-globin to form celloplasmy. And what is the gene associated with Wilson's? It is called ATP7B gene, which is present on chromosome 13. ATP7B accounts for 90 to 95% of the plasma copper. And what is the strain of choice? Rhodamine and ribinic acid for copper. Rhodamine and ribinic acid, and orsin for copper associated protein. And can you name any other test where the orsin is actually used as a very important thing? One is actually the Australia antigen, that is hepatitis HbSAg. Orsin, acetoorsin is actually the strain of choice. Acetoorsin, that is HbSAg demonstration, the typical Australia antigen. And the another strain of choice is orsin again for a dark body demonstration. This is the best strain available, dark body demonstration in bacteria. The dark bodies are very well stained with orsin, and this is the strain of choice. Apart from a pop strain, pop strain is actually not very sensitive for dark body, but this is again being used as a second choice, apart from orsin. So the strain for copper is rhodamine and ribinic acid, and orsin again is used as a copper associated protein. This is hemochromatosis, and again there is a question in hemochromatosis. What is the which is the cell where the initial deposition of hemosiderin in primary genetic hemochromatosis? The choices were hepatocytes, the Kupffer cell, the space of Bessy, or endothelial cells. Which is the cell where you get initial deposition of hemosiderin pigment in primary genetic hemochromatosis? And which is the cell that is initially deposited, initially involved in secondary hemochromatosis? Because both are different. In primary genetic hemochromatosis, it is hepatocytes. But in secondary genetic hemochromatosis, secondary hemochromatosis, it is Kupffer cells that is affected. What is the significance of space of Bessy? Amyloid deposition starts in space of Bessy. Both these three are important. Primary genetic hemochromatosis, it is the hepatocytes that is first being affected. In secondary hemochromatosis, what are the causes? Thalassemia, sideroblastic anemia, then chronic alcoholic liver diseases, multiple transfusion, all are actually the causes. Here we start with Kupffer cells. But when it becomes a clinically full-blown disease, you see that the entire liver is affected. Okay. And the space of Bessy, all with amyloid deposition. Okay. And what is the strain of choice? Pairs or questionable. And can you make a diagnosis here? It is a cirrhotic nodule, right? A nodule which is well separated, and you see that it is a well separated nodule. So it is a cirrhotic nodule with a Prussian blue positivity, means that this is a hemochromatosis induced cirrhosis. Right? Okay. Angiosarcoma of liver have been associated with chloroplast. What are the other chemicals? Polyvinyl chloride, chloroplast, as well as arsenic. These are the three chemicals associated with angiosarcoma of the liver: chloroplast, polyvinyl PVC, and arsenic. And what is the role of arsenic in any other tumor? Basal cell carcinoma of the skin. They produce BCC of skin, arsenic. Oral contraceptive, OCD, they are producing hepatic adenoma or liver cell adenomas. Hepatitis B virus, they produce hepatocellular carcinomas and chronic hepatitis also. Hepatitis C virus produces predominant cause of chronic hepatitis, and asbestos, we have mentioned the different malignancies associated with asbestos. OCD, it is liver cell adenoma. Hepatitis B, hepatocellular carcinoma. Asbestos, bone carcinoma, mesothelioma, CLL having same stomach and same colon. So this is a hepatocellular carcinoma. Most of the hepatocellular carcinoma can be multicentric in origin. So what is the common problem as far as the FLEC is concerned? Because the most important investigation, that is the primary investigation that can be done, is actually a primary aspiration cytology. So here the problem is a primary versus a metastasis, because liver is a very common site for metastasis. So metastasis can be again be multicentric. So that is a big problem in primary aspiration cytology. Another problem is actually, this is a hepatocellular carcinoma. This, you see the normal liver is here, and this is, even though it is a typical adenocarcinoma, they never produced any glandular pattern. You just get a trabecular pattern, never be a. So glandular pattern, even though it is an important feature of any adenocarcinoma, some organ, the adenocarcinoma will not produce any glandular pattern. The best example is actually hepatocellular carcinomas. Hepatocellular carcinoma should be differentiated from a cholangiocarcinoma, which arises from the bile duct epithelium. Even though incidence-wise the cholangiocarcinomas are actually pretty rare, when you compare with HCC, you see that the difference, the distinguishing the HCC from cholangiocarcinomas are extremely difficult, even with classical histopathological examination. Okay. Consummate bodies are apoptotic cells, cell inclusion, intermediate filaments, and cataractal bodies. They are nothing but apoptotic cells. Any other example of apoptotic cells? It is civet bodies in lichen planus. CIVATTE. Civet bodies in lichen planus. That is the apoptotic body. Invisible body macrophages in lymph nodes. For example, you see the starry sky pattern in Burkitt lymphoma. They are apoptotic cells or apoptotic bodies. Okay. Cell inclusions. What are intermediate filaments? Intermediate filaments are nothing but they are actually intermediate between thin and thick filaments. That is known as the cytoskeletal elements. Which is the thickest cytoskeletal element? The thinnest is actin and thickest is microtubules. Okay. The thickest is microtubule, the thinnest is actin, and myosin is fairly thick, but it's actually inferior to microtubules. So intermediate filament means that any filament which is actually a diameter which is intermediate between actin and myosin is called intermediate filaments. Okay. And what is the example of intermediate filament? Cytokeratin. Cytokeratin, that is known as Mallory hyaline in alcoholic hepatitis. So intermediate filaments here in respect of liver, it is meant for a Mallory hyaline, which is an example of cytokeratin. And where you get karyolytic bodies? In necrosis. The pyknosis, the karyolysis, the karyolexis, all are actually the spectrum of changes you get in necrosis. So what is a ballooning degeneration? Any acute insult of the liver, they can show, the hepatocyte can show a diffuse swelling, what is known as ballooning degeneration. So in acute alcoholic hepatitis, you get a ballooning degeneration. In acute viral hepatitis, you get a ballooning degeneration. So the ballooning degeneration means that it is an acute injury to the liver parenchyma. What is a febrile degeneration? Febrile degeneration you get only in cholestasis. Wherever you get cholestasis, this can induce a febrile degeneration of hepatocytes. So one is ballooning, the other one is febrile. And what are the changes you get in hepatitis C virus infection? This is the only hepatotropic virus which can induce a fatty change in the liver. That is HCV only. Hepatitis B virus never produce any fatty change. Only HCV can produce fatty change. Along with, you see lot of lymphoid aggregation. They actually produce lot of lymphoid aggregate and bile duct reactive changes. So the three changes that is produced by HCV is actually the fatty change, lymphoid aggregation, as well as bile duct reactive changes. ground glass hepatocytes. It is nothing but it is indicative of hepatitis B virus infection. Ground glassing, what is it due to? The ground glassing is due to abundant viral spheres and tubules in the cytoplasm of hepatocytes. Ground glass, you see that just like we say that there is a ground glass nucleus, here it is a ground glass cytoplasm. When you get a liver biopsy and the hepatocytes show a ground glass in nature, it is indicative of hepatitis B virus infection. Obviously, you see that other causes can be associated with drug-induced. We will come to that. But otherwise, it's always a HBV infection, and the ground glassing is due to viral spheres and viral tubules. So, two important features, the morphological feature for hepatitis B virus infection is the ground glass hepatocytes with stand-up nucleus is equal to HBV infection. When you get a liver biopsy, you get the ground glass hepatocytes with standard nucleus equal to an HBV infection, and the standard nucleus is due to abundant intranuclear HB core antigen, HBCH. And what are the two patterns of cell death? It is cytolysis and apoptosis in liver. Balloon hepatocytes and acidophilic bodies found in the liver biopsy is most indicative of balloon dehydration. What is it? Any acute infection, alcoholic and acute viral hepatitis. It involves cardiac cirrhosis and primary biliary cirrhosis. And the second one, acidophilic body, very good. In alcoholic hepatitis, not in a viral hepatitis. Okay. In acute viral hepatitis, you get councilman bodies, not Mallory Highland or acidophilic body. So what is the answer? A. Alcoholic hepatitis and not acute viral hepatitis. But in primary biliary cirrhosis, you can get Mallory-Highland. So there are list of conditions where you get Mallory-Highland, starting from alcoholic hepatitis, then primary biliary cirrhosis, alpha-1 antitrypsin deficiency, Wilson's disease, Indian childhood cirrhosis. All these conditions you can get Mallory-Highland. Once again, alcoholic hepatitis, the first and foremost condition where you get Mallory-Highland, then primary biliary cirrhosis, rare condition, then alpha-1 antitrypsin deficiency, Indian childhood cirrhosis. All these conditions you can get Mallory-Highland and Wilson's disease. Okay. Alcoholic hepatitis, it is called steatohepatitis. You see the hepatocyte swelling and necrosis, that is called balloon dehydration. Mallory-Highland, that is intermediate filament, cytokeratin, neutrophilic reaction, fibrosis and cirrhosis, that is the long-term complication. Acute hepatitis, you get balloon dehydration again, cholestasis and bile plug in canaliculi. There can be bridging necrosis, there can be councilman bodies, incessant hyperplasia, and portal tract showing mixture of inflammatory cells. What is all this? Sometimes you see that the inflammatory cell does spill over to the adjacent parenchyma, and this is called interface hepatitis. You see that usually the inflammatory cells are limited to the portal tract. When they cross the limiting plate and spill over to the adjacent parenchyma, this is called interface hepatitis. This is the Mallory-Highland event that is very typical of alcoholic hepatitis. Cirrhosis? Cirrhosis can be divided into micronodular and macronodular. Macronodular means that more than 3 mm nodule, and micronodular means that less than 3 mm. Okay. Don't confuse this with microvesicular and macrovesicular. This is exclusively for fatty change. What is microvesicular fatty change? In a single hepatocyte, you get multiple small vacuoles are seen, but the nucleus is central in position. But in a macrovesicular fatty chain, a single big vacuole pushing the nucleus to the periphery. That is called a macrovesicular fatty chain. Don't confuse this is micronodular and macronodular. This is gross appearance, the other one is a light microscopic appearance. This is cirrhosis, typical cirrhosis, and these are the regenerating nodules. That is, so for the definition of cirrhosis, often you see that the cirrhotic nodules are actually separated by fibrous septa, tissue, and there should be appearance of regenerating nodules. This is cirrhosis associated with fatty chain. So what could be the cause? Could be alcoholic hepatitis, alcoholic cirrhosis, because alcoholic cirrhosis start with hepatic, you see the classical fatty chain. Okay. All of the following genes mutated in colorectal cancer are tumor suppressor genes except. RAS is an ongoing, rest are all tumor suppressor genes. APC is in familial adenomatous polyposis, which is it's a hereditary polyposis. BCG is deleted in colonic cancer, it's a tumor suppressor gene. P53 is the classical prototype of tumor suppressor gene, and RAS is an ongo gene. Okay. I think some questions may not be there in that about. Okay. Diffuse mucosal damage of body and fundic mucosa seen in chronic gastritis is a feature of. Is a feature of atrophic gastritis or autoimmune gastritis. Where H. pylori-induced gastritis is always andral gastritis. Even though it is called pan-gastritis, predominantly the andron is involved. So this is almost equal to andral gastritis. That is H. pylori-induced gastritis. But autoimmune gastritis, the damage is usually limited to the body and fundic mucosa, and always they spare andra. That is the typical atrophic gastritis you get in pernicious anemia. Okay. And post-surgical it is the anastomotic sites you get the gastritis, and radiation induced you get the pan type of gastritis, because you see that radiation is actually involved in the interior mucosa. Following a tour of H. pylori-induced gastritis except often present as andral gastritis, organisms are easily demonstrated by genes of stain. Is it right? Which is the stain of choice? Warthin-Starry. That is a silver stain. But Giemsa is equally good. Giemsa is the most preferred stain, even though the textbooks say Warthin-Starry, which is a silver stain, is the choice. Most of the lab they use Giemsa, which is a Romanovsky stain. It's a very good stain for H. pylori demonstration. Intraepithelial lymphocytes and subepithelial plasma cells are a feature. No, it is only neutrophils. It is neutrophilic collections. You never get lymphocytes and plasma cells as a feature. It is neutrophilia. H. pylori has got a tropism for gastric epithelia and not found in regions of intestinal metaplasia. Only when the pH is acidic, you get the presence of H. pylori. Even though they see most of the H. pylori gastritis, they end up with chronic gastritis. And chronic gastritis is a condition where you get a marked intestinal metaplasia. But you will never get H. pylori in areas of intestinal metaplasia because the pH is always alkaline there. You understand? Okay. So H. pylori gastritis, they always produce chronic gastritis. What is the hallmark of chronic gastritis? Intestinal metaplasia. There is a stomach glands, they become intestinal type of glands. With a lot of goblet cells, etc. And you will never get this organism in those type of metaplastic glands. Only in normal glands you get. Okay. So what is the wrong statement? It is intraepithelial leukocytes. Atrophy is quite frequently associated with this, actually the previous one. Atrophy is quite frequently associated with autoimmune gastritis. It is absent android damage. Pan-gastritis is a feature of H. pylori, but predominantly is called android gastritis, not pan-gastritis. Active inflammation is signified by the presence of neutrophils within gland. It's very important. So only neutrophils you get. And where you get? In which the organisms are seen abundant in the superficial mucosa, they are never seen beyond that. Submucosa and all this, the total organism is totally absent because the visualizing power of this organism is very low. They are seen only in normal. That is actually the superficial mucosa, and pancreas high levels of interleukin-1 beta production. Organisms seen in the superficial mucous layer and among the microvilli of epithelial cells. They never invade the mucosa. Silver stains are Barton's-Starry, and this is Romanowski, not a silver stain, Giemsa. Organisms are absent in areas of intestinal metaplasia. Very, very important. Yes, pylori. Which of the following is not an anterior mediastinal tumor? Yes, simple. It is schwannoma, very good, posterior mediastinum. Which is the lymphoma that can occur in the anterior mediastinum? The first class we actually discussed that. If it is Hodgkin, nodular sclerosis Hodgkin. If it is non-Hodgkin, this type of NHL can present as mediastinal mass. The 15-year-old boy with mediastinal mass, lymphoblastic lymphoma. Okay. These two types. Of this, the common is actually lymphoblastic lymphoma. Next to that, this Hodgkin, only nodular sclerosis. These subtypes of Hodgkin never associate with EB virus infection. Two types. Hodgkin lymphoma subtypes which is not associated with EB virus infection. One is the lymphocyte dominant Hodgkin, right? And the other one is nodular sclerosis. Okay. The lymphocyte predominant Hodgkin, what is it called? It is called the non-classical type. Okay. The Hodgkins are actually broken into classical types and non-classical types. The classical types start with mixed cellularity, nodular sclerosis, lymphocyte depleted, lymphocyte rich, right? And what is the marker for lymphocyte predominant that is non-classical? There is CD50 negative, CD30 negative, CD20 positive and BCL6 positive. Okay. A tumor seen in adolescent girls and young women. Exclusively seen. In a 15-year-old girl, we get this tumor. And earlier, the problem was that they almost mimic pancreatic carcinoma, the classical pancreatic adenocarcinoma. But here, the tumor is almost benign. You see that almost often they are benign, and excision is enough to make a cure for this patient. This is called papillary solid and cystic tumor. And the common terminology nowadays appeared in books are SPPT, solid pseudo-papillary tumor. Solid pseudo-papillary tumor. And papillary and solid epithelial neoplasm, papillary cystic neoplasm, cystic solid papillary carcinoma. All these are actually synonyms. Anyway, you see papillary may be there, sometimes solid may be there. So the common terminology is solid SPPT. They present as palpable abdominal mass, surgical treatment prognosis is excellent, exclusively seen in young females, and mimicking a pancreatic adenocarcinoma clinically. Okay. Which of the following diffuse interstitial lung disease is not associated with granulomatous formation? Answer is silicosis. But silicosis can coexist with tuberculosis. What is known as silicotuberculosis? But silicosis per se is not a granulomatous condition. While borreliosis is a granulomatous condition, sarcoidosis you get is characterized by non-caseous granulomas. What is known as a naked granulomas. Why sarcoid granulomas are called naked granulomas? granuloma. Usually a granuloma is formed by, you see that a tuberculous granuloma, there is central caseation surrounded by epithelial cells and Lancaster giant cells, and this granulomatous reaction is surrounded by a rich lymphocytic infiltrate. That is known as a lymphocyte cuff is there. And this lymphocytic infiltration is absent in sarcoid granulomas. So they are exposed granulomas, what is known as naked granulomas. Right? Hypersensitivity pneumonitis, classically you get, it's a granulomatous condition, what is known as the Bede slum, the pigeon Bede slum, the farming slum, just like that. And again you see that most of these cases, they are represented by granuloma formation. And what type of hypersensitivity is hypersensitive pneumonitis? It is a single burst response. You should go only for the type 4 hypersensitivity. Then there is actually a type 3 hypersensitivity applicable also. It is a multiple choice result of PGA. You can go for the type 3 also. Otherwise, so type 4 hypersensitivity reaction. You see that the lymphocytic infiltration is actually not seen. This is lung and this is a sarcoid granuloma. And which is the most common pneumoconiosis worldwide? It is silicosis. Which is the most common granular nephritis worldwide? IgA nephropathy. Right? It is IgA nephropathy. And silicosis is currently the most prevalent chronic occupational disease in the world. Inflammation of crystalline silica, and you see that the quartz, the cristobalite and tridymite are actually the different types. And ingested silica particle cause activation and release of molecules by primary macrophages, which produce a lot of intermediate amount. What do you call this together? IL-1 and TNF together? Acute phase reactants. This is called acute phase reactant, which is for a very important during acute inflammation. A chronic inflammation, fibronectin and oxygen free radicals. Silicoid nodules constantly arrange hyalinous collagen fibers, and you can visualize the silica particles which is weakly birefringent under polarizing microscopy. Heart granulomas are seen in all except soft granuloma, tuberculosis. Why? Caseation is there. So, you see that? Answer is tuberculosis. All others are characterized by, not characterized by any caseous necrosis. Sarcoid granuloma, non-caseous granuloma. Borreliosis also you get the epithelial granuloma, caseation may be absent. And fungal infection, fungal granulomas, again gangrene, usually a non-caseous type of granulomas. So what type of reaction you get in a fungal granuloma? Along with the classical granulomatous reaction will be there. Along with that you get the immunoglobulin deposition in the tissue. What is known as Splendor-Hoffney phenomenon. You heard of that? Okay. That is again a recently asked question. Splendor-Hoffney phenomenon. You get in fungal infection. The fever hypermycosis. What is fungal infection? Because it's actually an antigen-antibody reaction, and this is seen as an eosinophilic areas in tissue site. Splendor-Hoffney phenomenon. The most common cause of interstitial pneumonia, that is primary atypical pneumonia, is mycoplasma pneumonia. Why it is called atypical pneumonia? What is typical of a pneumonia? Alveolar exudation. Alveolar exudation. Any pneumonia is characterized by alveolar exudate. The lobar pneumonia, stage of congestion, the stage of blood hepatization, stage of brain hepatization, stage of resolution. So alveolar exudation is very, very typical of pneumonia, and this exudate is absent here. That is why probably it is called an atypical type of pneumonia. So it is exclusively due to a mycoplasma pneumonia. You see that this is is a mycoplasma pneumonia. Here predominantly the inflammation is limited to the interstitium. That is why it is called interstitial pneumonia. Primary atypical pneumonia is actually the synonym is interstitial pneumonia because the inflammation is actually, this is the alveoli and this is the interstitium. The interstitium is very much congested and you get a lot of inflammation of the interstitium. That is one of the interstitial type of pneumonia. And you see the alveoli is totally free of exudate. Okay, this is an important feature. So acute respiratory febrile illness confined to alveolar septa and pulmonary interstitium and atypical because moderate amount of sputum is there, absence of physical findings of consolidation. That is again adds to the atypical. You will never get physical features of consolidation. In any pneumonia we look for that, right? And this is absent in interstitial pneumonias. And moderate elevation of the vesicle, lack of alveolar exudation. Mycoplasma pneumonia, influenza types A and B, and respiratory syncytial virus infection all are actually producing this classical interstitial or atypical pneumonias. Here again, respiratory destruction is seemingly out of proportion with the physical and radiographic finding. You see that the physical and radiographic findings are actually not very marked, but still you see that the actual destruction is much severe. But in any bacterial, the usual pneumonias, we can correlate with the X-ray picture as well as the clinical thing. The test for mycoplasma antigen can be nowadays being done and PCR test can be done for your mycoplasma DNA. Lymphomas of GIT occur commonly in most common site for extranodal lymphomas are stomach. Stomach is the most common site and generally the small intestine is coming. It is the stomach. And the most common site for yeast is also stomach. Gastrointestinal stomach tumor is also, it is stomach. So what is the most common percentage of lymphoma? You see it's a mesenchymal tumor, arises from the serosal aspect, not from the mucosal aspect. If it is a mucosal tumor, it is a carcinoma, right? It is from the mesenchyme. Here you see the mucosa is not involved, but they compress the mucosa, producing a intestinal type of obstruction or whatever it is. And this has got a typical, what is known as a fish flesh appearance. Very soft in consistency. Any tumor which is predominantly composed of lymphocyte has got a soft consistency. Because lymphocytes are very soft, fragile. So if a tumor is composed of, so lymphoma has got a soft consistency. This is what is known as a fish flesh appearance. This is a maltoma basically. Maltoma is nothing but mucosa associated lympho-tissue lymphomas, that is called maltomas. And this is the most common stomach lymphomas. The most common lymphomas of the GITs are actually maltomas. Most common site is stomach, the most common type is maltomas. Okay. Typically it is a basal lymphoma, basal nature of a low-grade nature. Not a very high-grade lymphoma, it is a low-grade lymphoma. And what is this histology tells you? This is an important pathognomonic feature of maltoma is, it is a lymphoepithelial lesions. See, the whole thing is actually lymphoma cell. All these these are not normal lymphocytes, they are actually lymphoma cells, right? All these are actually lymphoma cells seen in the mucosa, in which you can see that the normal mucosal glands may go trapped. They look like trapped. It is called lymphoepithelial lesion. It is pathognomonic of maltomas. 40% of lymphoma arise in sites other than lymph node. What do you call that? Extranodal lymphomas. And gut is the most common site for extranodal lymphomas. The primary GIT lymphoma, see what is the definition? For example, if you say if the stomach is the primary, whether it's an extranodal lymphoma, that is again very important. We should rule out a nodal lymphoma which is extending to the stomach. Because the lymphoma occurring in the para-aortic lymph nodes, right? And you see that the entire lymph nodes are involved and they are actually fairly big and they infiltrate the region of stomach or intestine. It is not an extranodal lymphoma. It is a nodal lymphoma. So, the definition wise, a primary GIT lymphoma exhibit no evidence of liver, spleen, and mediation lymph node involvement or bone marrow at the time of diagnosis. It is important because nowadays we have the imaging modality, we can pinpoint which all organs are affected, which all nodes are affected, and we can do a bone marrow aspiration and rule out any bone marrow infiltration. Then only we can say, see what is the importance of that? To say it's a nodal lymphoma or an extranodal lymphoma. Because surgery is an important part of extranodal lymphoma. If it is a gut lymphoma, the first part of treatment is actually excision of that part. But surgery is not a part of nodal lymphoma. That is very, very important. And in an extranodal lymphoma, again suppose you get recurrence, the same site is again involved. Again the intestinal or stomach is actually involved. So it is very, very important to locate the nodal lymphoma from extranodal lymphoma. Then for any GIT lymphomas, we can get a lot of clues. One, we look for any background picture. What is the background? Because we look for chronic gastritis. Chronic gastritis is due to what? H. pylori. And maltomas will be always related to H. pylori infection, right? So we look for or ask the history of chronic gastritis in this patient. And chronic sprue-like syndrome, what is that? It is a T-cell lymphoma. We can ask for the history or look for a chronic sprue-like syndrome. Natives of Mediterranean origin. What is that? Mediterranean lymphoma. What is the common name? IPSI. Immunoproliferative small intestinal disease related lymphomas. So IPSI lymphomas are totally endemic. You are getting the Mediterranean regions only. And we can actually ask for that. And patient with congenital immunodeficiency. Most of the primary immunodeficiency, they are complicated by lymphoma development later. And HIV infection because of the immunocompromised nature, and ask for history of post-transplant. Because post-transplant individuals are always immunocompromised. Okay. So this sort of history may be there. So again that is important background that can actually think for a extranodal lymphoma. We can get both the B-cell NHL and T-cell NHL in GIT lymphomas. Non-lymphomas are the commonest. IPSIP, Burkitt's and post-procedure associated lymphomas are there. Coming to the maltomas, it is a low-grade lymphoma, focal or extensive plasma cell infiltration. You see, you can get extensive plasma cell infiltration. Behave as focal tumor amenable to surgical excision. Relapse occur exclusively in GIT, and 11-18 is the relatively common translocation. 11-14 for mantle cell, 11-18 for maltomas. That is API2 and MLT fusion gene. CD5 positive, CD10 negative. Sorry, CD5 negative and CD10 positive. Only in CLL and mantle cell you get the CD5 positivity. CLL and SLL. So the lymphoma counterpart of CLL is SLL. SLL and mantle cell you get CD5 positive. SLL is actually CD5 positive, CD23 positive, while mantle cell is CD5 positive and 23 negative. Here both are negative for a mantle cell, sorry, maltomas. Stomach being the most common set, 55 to 60%, followed by small intestine, and lympholytical lesions are pathognomonic of maltoma. Okay, large giant cells are found in exclusively seen neonatal hepatitis. You get neonatal hepatitis. You see, neonatal hepatitis you can get what is known as pan-lobular giant cell formation. In the liver lobule, you get giant cells. You get a lot of giant cells here. You get a lot of giant cells scattered here. And these are all giant cells. This is called a pan-lobular giant cell formation. And neonatal hepatitis and extrahepatic biliary atresia is actually very closely mimicking thing. And you see that both are actually very important to differentiate because extrahepatic biliary atresia, you see surgery is early indicated. If you get a late surgery, you see that once the cirrhosis starts, you see that this is the irreversible stage. Cirrhosis, the collagen deposition is the irreversible stage in liver disorders. Once cirrhosis started, nothing is possible. Okay. So but in immunity hepatitis, most commonly the surgery is contraindicated because most often it is actually drug associated. So this is actually an early phase of cirrhosis, but HLD-wise, the early phase of cirrhosis cannot be well monitored. You need some special stain. What is a special stain to delineate the early cirrhosis in liver biopsies? What is the stain of choice? Yes, it is called trichrome stain, nascent trichrome or mangism. You see that? The same thing you see here with the cirrhosis. This is a liver nodule slowly separated by fibrosis. This is an early part of cirrhosis which cannot be picked by HLD stain. Because only when you get a full-blown nodule which is well separated from the liver nodule, and that is called a cirrhotic nodule in HLD, but early phase of cirrhosis we need some special stain. What is one? A trichrome stain. A trichrome stain means that three different tissues are stained in three different colors. Trichrome, three colors given to, three different colors given to three different tissues. Collagen is taking one color, and pathol cells of the hepatocytes is taking another color, and some other cells are taking another color. Here the collagen is taking a blue color, that is why this is the liver nodule separated by collagen. Okay, so this is called a mangism or nascent trichrome. Both are different stain of the same nature, that is all together called a trichrome stain. So neonatal cholestasis is actually, what is neonatal hepatitis? Neonatal cholestasis or hepatitis are not specific entities. This is almost like a pancytopenia. Pancytopenia is not a diagnosis. It is an entity where you can make several diagnoses, starting from aplastic anemia, leukemia to so many conditions, right? And here also neonatal hepatitis, it is actually a neonatal cholestasis or hepatitis which are not specific entities or necessarily not inflammatory also. The finding of neonatal cholestasis should evoke diligent search for recognizable reasons like toxic, metabolic and infectious causes. But most often it is idiopathic, that is 50%. So they classically present with jaundice, dark urine, light or acquired jaundice with hyperproteinuria. So this is actually a spectrum of disorder where actually you should make a lot of investigation to decide which is the cause. But most often 50% of causes are actually idiopathic. The other causes can be bile duct obstruction, neonatal infection, CMV, bacterial sepsis, toxic like drugs, metabolic conditions like pyrosinemia, Niemann-Pick, etc. So what is the histological finding? Lobular disarray, pan-lobular giant cell transformation. This is the most important thing. Pan-lobular giant cell transformation. Prominent hepatocellular and canalicular cholestasis will be there, and signs of extramedullary hematopoiesis is there. Okay. Which is the most common organ where you get extramedullary hematopoiesis? Why? In embryo, you see spleen is one side where you get hematopoiesis. So the microenvironment is very fitting for hematopoiesis, spleen remaining spleen. So the most common extramedullary hematopoietic site is actually spleen, right? That is why in CML you get a huge spleen, right? Okay. Myelofibrosis you get a huge spleen like that. The pigment in liver in Gibbon-Johnson syndrome is myelin, hemosiderin, bile, lipation and none of the above. Yes? None of the above. They are myelin-like, but they are not myelin. So HLD-wise, they look like myelin pigment, but nasal fontana will be negative. They are not myelin. So answer should be none of the above. You see that this is the table from Robbins again show. It is Gibbon-Johnson. Inborn biliary escalation of bilirubin glucuronides due to a canalicular membrane defect. Pigmented cytoplasmic globule chorioepinephrine metabolite. They are chorioepinephrine. And they are not myelin, but look like myelin in HLD stains. Okay. is for mainly nasal fontana, stain of hemocele, veins or procedure by, what is the stain? Used in tissue biopsies. The same functions, the stain can be used in biopsies also. Lipofuscin, what is lipofuscin? Pigment, wear and tear pigment. The telltale sign of aging is lipofuscin. Okay. What is a stain? There is no use for any stain. You see that any tissue you get some older cells, senile cells, that can show lipofuscin. So this is not indicated, and we never use any stain for lipofuscin demonstration also. And you see that nasal fontana is actually for melting, veins for hemocele, and vulgosa and iron red for calcium. Okay. Vulgosa and iron red for calcium. Usually this vulgosa that is used. This question may not be there, but simple beautiful question. All of the following pathological features may be found in pancreatic pseudocyst except. What is the answer and why? Mucinous epithelial lining, right? Yes, a pseudocyst never have any lining epithelium. Only a true cyst has got a lining epithelium. All other features regarding the pseudocyst is actually correct, except a mucinous epithelial lining. Horizontal fiber is a feature of epithelioma, anaplastic astrocytoma, glioblastoma multiforme, pilocytic astrocytoma, and neuroblastoma. Simple question, answer is pilocytic astrocytoma. What is unique to pilocytic astrocytoma? This is exclusively seen in children. This is the most common primary malignancy you get in children of the brain. Exclusively seen in children, and what is the common site? Cerebellum, and not the cerebral hemisphere. Any astrocytoma, what is the most common site? Cerebral hemisphere, and not cerebellum, but cerebellum is commonly involved here. And the unique thing again regarding the most important thing is actually pilocytic astrocytoma should not be graded. Any astrocytoma, what is the most prognostic indicator? Grading. Whether the astrocytoma grade 1, grade 2, grade 3, and grade 4 is called GBM, glioblastoma multiforme. Okay. So the prognosis purely depends upon grading. Grade 1, the behavior is extremely good, and grade 3, it is actually somewhat anaplastic. Grade 4 is equal to dismal prognosis we get. But pilocytic astrocytoma is a histological type where you see that always they belongs to grade 1. So if you get a pilocytic astrocytoma, grading is not needed. It is always grade 1 with excellent prognosis. Okay. As the grading of astrocytoma is increasing, which are the histological determinants of grading? Grade 1, you never get this. Grade 4 or grade 3, you get a marker. You see, what are the histological determinants for grading? One is necrosis. Along with the cellular atypia, cytological atypia, neuromorphism, hypochromatism, any malignancy, even mitosis is important, necrosis is important thing, and apart from necrosis, which other thing, the most important thing? No, it is actually endothelial proliferation, vascular proliferation. Now with extreme of vascular proliferation in glioblastoma multiforme. What is known as glomerular body formation. You see that blood vessels are there with lumina. When you get endothelial proliferation, the endothelial cells may proliferate into the luminal aspect. So what they produce? They produce a solid glomerular-like structure. Because no lumina is seen, the whole lumina is filled with endothelial cell. So they look like an oval structure, look like glomerular-like structure. This is called glomerular body formation because of profound endothelial proliferation. Then, what is known as garlanding necrosis. is a garlanding necrosis? Extreme areas of necrosis. So surrounding this necrosis, you can see the viable cell, the nucleus of the viable cell, they look like a garland. What is known as a garlanding necrosis? These are two important features of glioblastoma multiforme. That is a grade 4 astrocytoma. So after grading this, we look for endothelial proliferation as well as necrosis. So this is polycytic astrocytoma. Occurring children and young adults located in the cerebellum, and what are the other four of moles of third ventricle and optic nerve. And grossly also this has got a very unique presentation. Usually occurs as a cyst with a neural nodule seen in the wall of the cyst. And prosencymal fibers are usually granular bodies, and what they represent? Glial fibrillary acidic protein, that is known as GFAP. Okay. Which one of the following disorder is not accompanied by steatorrhea? Tissue fibrosis, Cartwright syndrome, alpha-hereditary disease, and intestinal lymphangiectasia. Answer? Answer is Cartwright syndrome. They never produce malabsorption, only diarrhea, because they elaborate vaso-intestinal peptides. Cystic fibrosis, classically it is a malabsorption syndrome. Alpha-hereditary disease is actually IPSID, immunoproliferative small intestinal disease, that is known as belongs to Mediterranean lymphoma, and all these present as malabsorption. And another typical example of malabsorption is intestinal lymphangiectasia. So answer is Cartwright syndrome. It produces only diarrhea, not malabsorption. Sjögren's syndrome is characterized by all except bilaterally diffuse enlargement of salivary gland. What do you call that? Keratoconjunctivitis sicca and xerophthalmia. A dry eyes and dry mouth. The dry mouth is keratoconjunctivitis sicca and dry eyes is xerophthalmia. What is it due to? Destruction of the minor salivary gland. So what is happening in Sjögren's syndrome is nothing but the diffuse destruction of the minor salivary gland of the mouth as well as eye, that is lacrimal gland. So the glands are destroyed in the eye, it producing not here, it is a dry eyes and a dry mouth. Right? Diagnosis is made by taking biopsy of the lip. This is the gold standard. Because to study the minor salivary gland, you need a lip biopsy. Lip biopsy is said to be the gold standard. Lymphoidal system parotid and 40 times increase in risk for lymphoma and not for carcinomas. What sort of lymphoma? What sort of lymphoma you get? Marginal zone lymphoma. You take any chronic inflammatory lesions that is occurring in human body, which is purely autoimmune. Hashimoto's thyroid is an autoimmune condition. It is a chronic inflammatory lesion. And what is a long-term complication? Lymphoma development. Again, it is marginal zone lymphoma. Another location, atopic gastritis. Again, it is an autoimmune condition. And what is the complication? Maltomas. It is again an autoimmune condition producing a maltoma. And maltomas are in fact marginal zone lymphoma. It is called maltomas. And the third site is again a Sjögren autoimmune producing a marginal zone type of lymphomas, right? So keratoconjunctivitis sicca is actually dry eyes, xerophthalmia dry mouth. Primary form is called Sickle syndrome. And secondary is actually there is associated rheumatoid arthritis also. The secondary form, decrease in tears and saliva, and periductal and perivascular lymph node infiltration. That is the initial histological finding in urine biopsy. The ducts and vessels are actually surrounded by lymphocytes. Later there is fibrosis of lacrimal and salivary gland, major and minor cellular glands are actually affected. What is the investigation? SSA-RO and SSB-LA antibodies are detected in 90% of cases. SSA-RO and SSB-LA. Of this, more important is SSA-RO. Patient with high titers of antibodies to SSA is actually characterized by early disease onset, early disease duration, and extraglandular manifestation. Biopsy of the lip to study the myocellular gland is essential for the diagnosis of Sjogren syndrome, and NHL, which is a marginal zone lymphoma, is actually 40-fold increase in marginal zone lymphoma development. Okay. Following a true or peptic ulcer accept. Similar question. What is the answer? Occur mostly along lesser curvature, that is true. Associated with H. pylori infection, that is true. Gastrovocal force radiates in all directions. Yes, that is also a spot wheel or a cartwheel appearance. And how will you actually differentiate a malignant gastric ulcer from a benign gastric ulcer? What is the gross appearance? A malignant gastric ulcer, what is the key word in a malignant gastric ulcer? Rolled out margins with a heaping up of mucosa. Heaping up of mucosa with rolled out inverted margins. What is the heaping up of mucosa is the key word. That is the most important feature. What about the floor of the ulcer? Always dirty in a malignant gastric ulcer and very neat in a benign gastric ulcer because of the acid peptic digestion. Okay. They never show necrosis or dirty floor in a benign gastric ulcer. Gastric outlet obstruction indicate development in benign ulcer also within the gastric outlet obstruction. But again, I remember a question. In India, which is the most common presentation of CS stomach, gastric outlet obstruction. This is actually not seen anywhere in Western countries because they make a early diagnosis. Diffuse type gastric cancer is characterized by exophytic growth of tumor. A diffuse gastric ulcer is never producing a exophytic tumor. It's always for intestinal type, never for a diffuse infiltrating type. Excessive glandular formation, very good, only for intestinal type. Diffuse means that there is no gland formation. Intestinal type, because of intestinal metabolism, the corresponding glands which actually producing the tumor manifestation, they again producing a glandular manifestation. So suppose glands are present in a CS stomach, it is always intestinal type and not a diffuse infiltrating type. Intestinal metaplasia is a pre-runner for intestinal type. So what is the answer? Thick margin cells. You see the thick margin cell, there is absolute absence of gland formation, and this is a vessel, not a gland. You see no gland formation is there. This is a diffuse infiltrating type. Okay. Low-grade intestinal lymphoma include all except. What is the exception? Burkitt lymphomas. Burkitt lymphoma can actually, again, this can occur as an external lymphoma. And what is the common location of Burkitt lymphoma? It is retroperitoneum, ovaries, which is more common site. And GD is again a rare site, and here it is a high-grade lymphoma. One of our former student actually got this Burkitt lymphoma of ovary, and when she was in 8th standard, and from our department the diagnosis is actually made, and I think she now completed her PG. Is the best outgoing student of this college for MBBS. Again for SSLC, I think rank holder, PDB rank holder. That time I think this plus 2 was not there, so we PDB. And now she is actually her family is completed, and one ovary was removed along with the tumor. Excellent prognosis, curable one, because high-grade lymphoma, but especially for external lymphoma, these sort of things are there because excision is actually 50% will be over. Okay. true of pleomorphic adenoma except. Common site is parotid gland? Yes. Cancer when develops of squamous cell carcinoma? No. Adeno or undifferentiated. You never get squamous cell carcinoma in a complicating pleomorphic adenoma. Not fully rhizoid pseudocapsule shows a bifacial pattern that is epithelially and mesenchymal. Usually adeno or undifferentiated. Never squamous. Following are inherited forms of colorectal cancer except. This is a repeat question we are defining. There is a mistake here. It is hereditary flat adenoma, FLAP, not fat. Flat adenoma syndrome. Hereditary flat adenoma syndrome is actually almost equal to an attenuated FLAP. Some textbooks is actually using this terminology for attenuated FLAP where you get lesser number of polyps and the incidence of malignancy is just 50%. So it is a variant. So what is the answer? Cow dung. Cow dung is producing only hamartomatous polyps, never be any adenomatous polyps, right? It's only hamartomatous polyps. All others are classical. FAP is the archetype, lymph syndrome is again you get inherited forms of colorectal cancer. They produces only hamartomatous polyps. The type of carcinoma arising from scars of lung. Previous inflammation, that is a complication. Adenocarcinoma, only adenocarcinoma. They are always peripheral. And only adenocarcinoma. From previous scarring, you get a carcinoma is a complication in the previous scarred areas. It is only adenocarcinoma. And again you get grossly a lung cancer showing cavitation is squamous cell carcinoma. These are all questions previously asked. Grossly if a lung cancer, they show cavitation, it is squamous cell carcinoma. Most common eye cell tumor is typically mesenchymal, right? Nowadays we don't call this actually, it is called PEN, pancreatic endocrine neoplasm, PEN. The entire group is actually grouped into what is known as pancreatic endocrine neoplasm, PEN, that is a modern terminology, single or multiple, benign or malignant, functional or non-functional. Because most of the non-functional, we actually never make a diagnosis because we never evaluate the patient for this. If it is functional, we will evaluate and make a diagnosis. But the problem here is actually whether they are benign or malignant, extremely difficult. Only metastasis, the presence of metastasis tell that it is malignant. Any other tumor where you get a similar pleomorphic, only the unequivocal evidence is only metastasis. Any other features for malignancy, the circulatory epithelial, invasion, local infiltration, may not be usually ultimately tell that it is malignant. Even if you get some local infiltration or invasion, sometimes this has got a benign behavior. So metastasis they are actually. And the three most common and distinctive clinical symptoms are hyperuricemia, hypergastrolemia, that is cholesterolism, and multiple endocrine neoplasia. The clinical features of mesenthymas are occur with blood glucose level less than 15 milligram percentage. That is a clinical triad is there. One is hyperglycemia below 50 milligram, the plasma glucose level below 50 milligram percentage, consists principally of serious manifestation, that is confusion, stupor and loss of consciousness, and precipitated by fasting or exercise and a primary delay by glucose. These are the clinical triad for classical insulinomals. In insulinoma, histologically one thing that is important is, you see that this is an insulinoma, well encapsulated, this can be mild and sunlight, and you get the amyloid deposition. 15 to 20% of insulinoma, you can get amyloid deposition. Okay. Histological scoring of chronic hepatitis does not include. See, any chronic hepatitis, liver biopsy is indicated. And from the liver biopsy, the pathologists actually, they do a scoring system. And the prognosis actually directly depends upon the scoring. And what is the scoring system? Known as, the scoring system is known as a historical activity index system, what is known as HAI system, HAI, or it is called nodal system. This is a previous terminology. This is called modified HAI system, HAI. So what is they include periportal inflammation. Definitely this is an important feature. Portal fibrose is the most important feature, and bridging necrosis is another feature, and cholestasis is not included in the bleeding of chronic hepatitis. Because periportal and bridging necrosis is a part, intralobular regeneration and focal necrosis, portal inflammation and fibrosis. And each one is allotted a particular score, and you add up the score, and the maximum possible total score is 22. Okay. But cholestasis is not a part of scoring system. Just remember that. Cholestasis. It is actually bridging necrosis, periportal fibrosis, portal inflammation and fibrosis. Periportal fatty infiltration of liver is seen with it is PEM, protein energy malnutrition. Very typically you got periportal fatty infiltration. The fatty change is exclusively around the portal tract. That is a feature of malnutrition. Alcoholism, you don't get the periportal fatty infiltration. It's a centrilobular fatty change you get. And viral hepatitis, the only virus that is producing hepatitis C virus, and precisely, this is a microvesicular fatty change. So actually, it's not the location. This actually the hepatocytes, they show multiple vesicles, microvesicular fatty change. So, what are the situations where you get microvesicular fatty change? That is actually a single vehicle displacing the nucleus to one side. You see, again, PN is an important cause for microvesicular fatty change. Location-wise, it is actually the periportal fatty change. But light microscopically, it is a macrovesicular fatty change. AIDS, vasospasm, steroid therapy, and here you get the periportal fatty change also. All these can produce periportal steatosis as well as they are all macrovesicular fatty change. In centrilobular fatty change, alcoholism, diabetes and other liver disorders you get. And it is centrilobular type of fatty change. But all are macrovesicular fatty change, and some are periportal and some are centrilobular. Coming to the microvesicular fatty change, you get the list of conditions where you get microvesicular fatty change. Acute fatty liver of pregnancy with a high morbidity and mortality rate. I think 30% of mortality rate is there. Reye syndrome, very classical. Drugs like sodium valproate, tetracycline, salicylate, ethanol can produce both micro and macrovesicular fatty change, but it is included more in favor of microvesicular fatty change. Then inherited urea cycle disorders, genic and vomiting sickness syndrome, and antiviral nucleoside analog, that is known as PRLD. All these can produce microvesicular fatty change. Once again, acute fatty liver of pregnancy, Reye syndrome, drugs like sodium valproate, salicylate, and tetracycline. Inherited disorder, urea cycle disorders, genic and vomiting sickness syndrome, and antiviral nucleoside analog PRLD. All this actually the Robbins is given separately, not in it's only in sentences, notice tables, and Harrison I think the list is actually more. But these are the usual one that is actually. OCDs can produce hepatic cell adenomas or liver cell adenoma. Chloroplast, you see that this is the list that is given. Ideally it is for angiosarcoma of the liver, but even for hepatocellular carcinoma and cholangiocarcinoma, cholestasis is actually indicated. And which is the cell that actually producing a granuloma formation? It is nothing but macrophage of the liver is called Kupffer cells. What is the macrophage of the blood? Monocyte. And macrophage of the tissue is called histiocyte. And macrophage of the CNS is called microglia. All these producing the classical granuloma formation. And hepatic granuloma, you get in conditions like sulfonamides, metheldopper, which is drug induced, phenylbutazone. All this can produce hepatic granuloma. And there is a special type of granuloma that is known as fibrin ring granuloma due to allopulmonal therapy. Fibrin ring granuloma due to allopulmonal therapy. And hepatic granuloma can be drug induced also. Apart from that classical granulomatous conditions, it can be drug induced. And what is pileosis hepatis? It is nothing but periportal sinusoidal dilatation. The sinusoids of the liver is getting dilated. That is known as pileosis hepatis. What is the common cause for pileosis hepatis? It's danazol therapy. Anabolic steroids like danazol, as well as OCDs and azathioprine. Of this, the danazol is the most important thing. Angiosarcoma of the liver is actually anabolic steroids, arsenic, chlorotrust, PDC and radiotherapy. One more thing is actually apart from it is anabolic steroids again can induce angiosarcoma. But the three classical one is actually the PDC, chlorotrust and arsenic. And where is the ethocell hypoplasia? Ethocell is actually a cell which actually a storage organ for vitamin E as well as they produce collagen. Ethocell is actually the source of collagen. In cirrhosis, the ethocell is actually getting activated and producing collagenization. So in hypervitaminous you get ethocell hypoplasia because this is the storage organ for vitamin E. Okay. Which of the following is not seen in Indian childhood cirrhosis? Yes, what is the answer? Fatty change. Fatty change is not a feature of ICC. You will never get fatty change in ICC because in the child cirrhosis, the cirrhosis, you get fibrosis, water inflammation, and we already highlighted that ICC is one condition where you get mild highlight. I think we can have the lunch break now. How many minutes we need? 35 to 40. We will reassemble by 2 o'clock, right? 2:05.